then it will reach up to 140, which is end diastolic volume. When end diastolic volume is there, ventricle starts to contract and it keeps on increasing. Whenever the pressure reaches 80, aortic valve will open, and the first half is rapid ejection, second half is slow ejection, and finally it will drop down and A will be there. A will be the opening point of the A is again the end systolic volume. So here points we can mention. A point is end systolic volume and AV valve should open, then only the filling can happen. The point B is end diastolic volume. After the end diastolic volume, when isometric volumic contraction starts, AV valve closes. Then point C, it's at 80. As you can see here, the aortic valve will open. Then finally point E is aortic valve will close here. Then only the isovolumic relaxation can happen. The same pressure volume loop I have written in events also. A to B, what is happening? From A to B, ventricular filling is happening. Then from B to C, this is isovolumic contraction. Then C to D is rapid ejection phase. D to E is it is ejecting. So it is slow ejection phase. Then E to A is again, it is the isovolumic relaxation. So same cardiac graph here represented in a flow volume loop. Here the volume is along the x-axis and pressure is along the y-axis. Why we have taken two parameters? Because 80 is the pressure of normal aorta and 120 till 120 it can raise the pressure during ejection. So coming to the jugular venous pressure. The jugular venous pressure, whenever any question is asked according to it, first thing is it is measured in the internal jugular vein. Even though we see it from the outside, it is the internal jugular vein which looks prominent, because external jugular vein, the course is kinky, which is not visible. So it is the internal jugular vein which is visible. So that is the vein which is used for it. And the recording shows something like this. And here we can see three upward deflections, A, C, and V. And there are two downward deflections, X descent and Y descent. This internal jugular vein, or the JVP, is directly connected with the right atrium. Here, as you can see here, it is connected with the right atrium. So that's why we have to always check on this side, right side, to look for the height of the veins. Here, whenever the recording is done, these are the waves which is included: A, C, V, upward waves, and X and Y descents. The upward wave A. So the logic is pretty simple. Whenever there is increased pressure in the right atrium, the deflection is going to be shown in the JVP. So whenever there is an atrial contraction, what is happening in the pressure in the right atrium? Obviously, it will increase because contraction, it should increase, and there will be a waveform which is seen in the JVP, that is the A wave. So A represents the atrial contraction, atrial systole, which is a ventricular diastole. Then C, please remember C as cusp. C for C, A for A, C for cusp. What happens is, ideally, whenever the contraction is happening, it should have emptied all the blood and the pressure should have dropped and it should come like this, ideally. But there is a slight bulge at C. There is a slight bulge which is happening at C. What is the reason is, because when the blood is emptied, there will be closure of the valve afterwards, and this will create a slight bulge. So there is not a smooth curve. This cusp is bulging into the atrium, creating a slight pressure. So this C is for the cusp, which is the bulging of the tricuspid. And this happens during an isovolumic contraction, because this closure of this valve happens during isovolumic contraction. Then V, ACV. V is for the venous return. Now the atria is relaxing, but it cannot relax. It cannot keep on relaxing. But the volume is being added by the venous return. So when the volume is increasing, what will happen to the pressure? Volume is increasing, but it is constant. There is no increase in size. It is constant. More and more volume I am adding. So that will be reflected in the JVP as an upward wave. V is for the venous return. A for atrial contraction, C for cusp, V for the venous return. Whereas the downward waves are the X and Y descent. X descent is relaxation of atria, and Y descent is due to emptying of atria. Because as you can see here, the venous return is filling up here, and finally when it opens up, it will reduce the pressure because of the slow and rapid filling phases. It will directly reduce the pressure. When this valve opens at the point of venous return, after venous return, what will happen? The valve will open and there will be a passive filling, rapid passive filling and slow passive filling. So at that time, the pressure will drop. Again, when atria contracts, only A wave can be produced. So the diagram will continue here and produce an A wave again, and there will be repetition of this cycle, keep on going. So the questions as usually are the abnormalities. So first coming to the A wave. When can a large A wave be produced? Whenever there is too much pressure in the right atrium, a large A wave will be produced. So a large A wave is usually produced in tricuspid stenosis. Whenever the tricuspid valve is stenosis, the right atrium has to put more pressure because there is a stenosis. Giant A wave or cannon A wave, still more larger A wave is produced, will be produced whenever there is a complete tricuspid obstruction. There is a complete tricuspid obstruction. When there will be an absent A wave, I have written it reverse. When there will be an absent A wave will be seen in atrial fibrillation. In atrial fibrillation, the atria is just shaking. It is not compressing. So as and when it compresses only, there will be a reflection in case of a JVP. But here the atria is fibrillating in atrial fibrillation. So there is no proper contraction of the atria. So obviously A wave will be absent in case of an atrial fibrillation. Then comes the CV fusion. C wave and V wave are fusing. C wave is due to the bulging of the tricuspid and V wave is the venous return. So both of them are fusing. So what could be the possibility? C wave is the bulging is happening. So during bulging, some volume is going in and venous return is also mixing with them. So it is nothing but the tricuspid regurgitation. So C wave fusion can happen whenever there is a tricuspid regurgitation. From regurgitation it is going and from venous return it is joining. So both the wave look merged. Then coming to the X descent. Prominent X descent can be seen in two conditions. One is the cardiac tamponade, another one is constrictive pericarditis. In both of them, there is severe contraction around the heart, so they will produce a prominent X descent. And Y descent. Prominent Y descent, it is particularly seen in constrictive pericarditis. So there is a confusion between this cardiac tamponade and constrictive pericarditis. How will you identify? First clue will be, we have simplified it here. First clue will be Y descent is present. As you can see in this diagram also, there is a Y descent present, which is seen in constrictive pericarditis. Whereas in tamponade, the constriction is very severe. The venous return from the venous return itself will not happen properly. So there is no Y descent, which is not allowing the blood to enter into the atria. There is no proper filling of the ventricles. So the Y descent is absent in case of a cardiac tamponade. And remember, friends, there is one important thing. The cardiac tamponade is an emergency condition. So immediately there is a constriction. So the presentation given in the question will be immediate. Another thing is the cardiac tamponade, there is severe obstruction of both the atria as well as the ventricles. So obviously there will not be ventricle contraction. Filling itself will not happen first, and there is no contraction, proper contraction will not happen. So obviously there will not be any pulse. The absent pulse also will be there in case of cardiac tamponade. So absent pulse, absent Y descent, immediate presentation, then go for cardiac tamponade. Some of the features are common. They would have given X descent, elevated JVP, Kussmaul sign. All three will be common for both the constrictive pericarditis and cardiac tamponade. But see to the key finding like Y descent. If Y descent is present, go for constrictive cardiacitis. If it is absent, going for a cardiac tamponade. And cardiac tamponade, always immediate presentation will be given. The patient suddenly collapsed, the patient came with absent pulse, something like that will be there in the clue. Coming to the cardiac output. So this is all about our JVP. Now coming to the cardiac output. Cardiac output, as all of us know, it is the amount of volume blood pumped by each ventricle in 1 minute. Then it can be given by stroke volume and heart rate. What is stroke volume? For one beat, how much ever volume is going out, that is the stroke volume. And all of us know it is around 90 ml. And for heart rate, the normal is 72. So the cardiac output is usually 5.5 liters. It comes to around 5.5 liters. Coming to the regulation of stroke volume. Stroke volume can be regulated by three things. One is the preload. How much blood is being filled into the heart. The preload for the heart is nothing but the end diastolic volume. The end diastolic volume is the preload. The preload is determined by the venous return. If the venous return is more, obviously the end diastolic volume will be more. So this increase in preload will increase the stroke volume. What is the law behind this? The law behind this is Frank-Starling's law. What does Frank-Starling law state that? Frank-Starling law states that there is the amount of contraction is directly proportional to the initial length of the muscle fiber within physiological limits. So if the muscle fiber length is increased within physiological limits, the force of contraction will be better. How can the muscle fiber length be increased in heart? Whenever you put more volume into the heart, obviously it will be increased. So that's why the increase in preload will increase the stroke volume with respect to Frank-Starling law. Second one is contractility. If I increase the contractility of the heart by sympathetic activity or with any drugs, then obviously the stroke volume will be increased. But the stroke volume will be decreased by the afterload. What is afterload? Afterload means the heart is pumping, but somebody is obstructing its pathway. For example, heart is this, aorta is this, and there is some obstruction here. So can I pump easily? Obviously no, because there is a load here which I have to overcome. So the resistance offered is the afterload, and it is determined by total peripheral resistance. Since total peripheral resistance takes into account of all the arteries, we cannot easily do it. The index is mean arterial pressure. So that's why hypertensive patients, their heart will fail early, because the mean arterial pressure is very high and the heart has to work against the increased load. Whereas the index for end diastolic volume is the index for the preload is the EDV, end diastolic volume, and it is determined by the venous return. So these are the factors that is regulating the stroke volume. And the other one which is regulating the heart rate. So we know that stroke volume into heart rate is the cardiac output. So stroke volume regulation we have seen. Now coming to heart rate regulation. Heart rate regulation primarily by the autonomic nervous system. Sympathetic will increase the heart rate, parasympathetic will decrease the heart rate. Again, this can be given in a curve form also. One is the end diastolic volume against the stroke volume. So the first blue color curve here is the normal curve. As you can see here, whenever the end diastolic volume is increasing, stroke volume also will increase. What is the reason? Because of the initial stretch of the muscle fiber, there will be an increase in force of contraction, which is given by the Frank-Starling law. But after this, we have drawn downward. Why does it happen? Because I told you Frank-Starling law will operate till a physiological limit. When this limit goes beyond, the heart is stretched beyond that, then obviously the performance will come down. And with sympathetic activity, there will be an increase in performance or an increase in stroke volume. Whereas parasympathetic activity, hypoxia, hypercapnia, all of them will decrease the heart rate as well as the stroke volume output. Then cardiac failure will mimic a curve something like this. As you can see here, will mimic a curve. Whatever EDV is there, heart has already failed. So if I increase the end diastolic volume, there is no use in increase. The heart cannot pump it even though there is more volume available. So we can compare here between the normal curve and cardiac failure curve and treatment part. So if I give a sympathomimetic drug or a cardiac inotropic drug, what it can do? It can increase and put the curve somewhere here. So the A is nothing but the digoxin. So if I try to reduce the volume in cardiac failure patient, we always give the diuretic. Why? Because if more and more load is there, again the heart is already failed. If more and more load is given, again the failure rate will be very high. So that's why the volume is reduced. So the drug here, which is reducing just the volume, end diastolic volume, so that further increase in the pressure, so that further load on the heart is reduced, is given by diuretics. And one beautiful drug can increase the contractility also, as well as reduce the volume also. That is nothing but the ACE inhibitors. All the prill hormones, captopril, lisinopril, they are given. What do they generally do is, the ACE inhibitors will block the angiotensin 1 conversion to angiotensin 2. So angiotensin 2, what it usually does is constriction. Now angiotensin 2 is not there, so there will be a dilation, venodilation as well as arterial dilation. If venodilation happens, what will happen to the venous return? All the venous return will stay in the veins, so the venous return will be reduced. So the preload on the heart will be reduced. So the ADV will be reduced. That is one thing. Next thing is arteriodilation. It does. Whenever arteriodilation is done, heart is there. We have dilated this part, for example, the outgoing part. So I have less resistance to pump. The total peripheral resistance is reduced. So here we are doing both things. One is the reducing the preload and reducing the afterload. So both will help the failed heart. So this is all about the cardiac output. Now coming to the blood pressure and its regulation. What is blood pressure? All of you know it is the lateral pressure exerted by the column of blood in the arteries, and systolic is the maximum pressure during systole, which is around 120, and diastolic is the minimum pressure during a diastole. Then coming to pulse pressure. What is pulse pressure? It is the difference between systolic pressure and diastolic pressure. And here the MCQ here is, the baroreceptors are most sensitive. The baroreceptors are most sensitive to which pressure changes? They will give you the option of systolic, diastolic, pulse, and mean arterial. The pulse pressure is the most important answer, because the baroreceptors are more sensitive to the change in pressure or the difference in the systolic and diastolic pressure, which is called the pulse pressure. Then the mean arterial pressure, the formula is diastolic blood pressure plus 1/3 of pulse pressure. So this is the mean arterial pressure. Coming to the regulation of blood pressure. Regulation of blood pressure can be done in 3 different stages. One is the short-term regulation, then is the intermediate, then long-term. Short-term is very, very important. Short-term regulation will have the baroreceptor, chemoreceptor, and CNS ischemic response. Let's try to sum them up. Then the intermediate regulation is nothing but the capillary fluid shift from the vessels. The capillary fluid will shift to outside. At the same time, from the interstitium, blood can come inside the vessels also. If the vessel volume is very, very low, from the interstitium, fluid will come to the blood vessels. So that is the stress relaxation of muscles. Then long term is by the renin, angiotensin, aldosterone system, which we'll study in the kidney. So coming to the baroreceptors, as we can see here, the baroreceptors, the term indicates baro. Baro means pressure. So these are nothing but the pressure sensors. These are the pressure sensors. What do they use? They'll sense the stretch. Whenever there is a stretch, there will be an increase in pressure that will be sensed by this baroreceptors. We have 2 baroreceptors primarily located, one in the aorta, which is called as aortic sinus, another one in the carotid, which is called as the carotid sinus. For the aorta, it is carried to the medulla with the help of vagus. For the carotid, the glossopharyngeal nerve carries it to the medulla. So let's see what happens whenever there is an increase in blood pressure. Our ultimate goal is to decrease the blood pressure now. That's what baroreceptor does. So there will be a stretch and impulses will go through vagi as well as glossopharyngeal, and they will reach the part that is nucleus tractus solitarius. They will reach this particular region in the brain. From here, they will give impulses to 2 places. Both are stimulatory. That is why glutamate is involved. Both are stimulatory. It will stimulate the CVLM as well as CIC. So what is the CVLM? CVLM is caudal ventrolateral medulla. So caudal ventrolateral medulla is stimulated and CIC is cardio inhibitory center is stimulated. Let's talk about the cardio inhibitory center. As the name indicates, cardio inhibitory center. Cardiac system is going to be inhibited. So they will give the vagal fibers. That is the parasympathetic. So what will happen to the heart rate? There will be a reduction in heart rate. If there is a reduction in heart rate, then obviously BP will be regulated properly. And coming to the CVLM, here we should pay more attention, because this CVLM, as and when it is activated, it will inhibit the RVLM. This region is very important. This will inhibit the RVLM. What is the function of this RVLM? If the RVLM is functional, it will increases the sympathetic flow. But right now we are inhibiting them. So RVLM main function is to increase the heart rate, increase the contractility of the heart. But right now we have inhibited the RVLM. So what will happen? There will be a decrease in heart rate, decrease in contractility. So what will happen to the BP? The BP will be decreased. So that is what happens in case of a increased BP. So whenever there is an increase in BP, what is happening? Parasympathetic system is getting activated. So decrease in heart rate. Then the sympathetic system is getting deactivated. Decrease in stroke volume. If heart rate is decreased and stroke volume is decreased, heart rate and the stroke volume will give us the cardiac output. So that will decrease the cardiac output, that will decrease the BP. The decrease in BP will do a reverse of it and increases the BP. Here what happens is the sympathetic outflow is increasing because RVLM will not be inhibited. RVLM will be active. RVLM is active, sympathetic outflow will be increased in case of a decrease in BP. So this is all about the baroreceptors. Then coming to the chemoreceptors. The baroreceptors are the one which actually acts normally. For example, I am lying down. From my lying down posture, I am standing up. I am changing my posture. I am taking a little walk. All these minute changes will be corrected by the baroreceptors. All our day-to-day activities will be corrected by the baroreceptors. Whenever the pressure drops below a certain level, like 70 mm of Hg, then comes the action of chemoreceptors. Chemoreceptors, as the name indicates, they senses the chemical. So this will be activated by decrease in PO2. Whenever there is a hypoxia or an increase in PCO2, hypercapnia, or an increase in H+. It will be sensed again by the aortic and carotid. Here it is not sinus, they have a separate body, rounded structures. So aortic body and carotid body. Sinuses are the baroreceptors and bodies are the chemoreceptors. So what they do is, whenever they get activated, they will activate the RVLM. So it will increase the stroke volume and increases the BP. So whenever there is a hypoxia, it has to supply blood to the other parts. So the pressure will be increased so that the supply is maintained. But whenever there is a mild hypoxia, the cardio inhibitory center is activated. So it will cause a bradycardia. That is the direct action. But most of the time, we don't see this direct action. What is the reason behind? Because moderate to severe hypoxia, if there is a severe hypoxia, there is an increase in respiration, there is an increase in stretch of the lung. This increase in stretch of the lung will again go to the CIC, and they will cause a they will inhibit the CIC. If the cardio inhibitory center itself is inhibited, what will happen to the heart rate? Increase in heart rate, increase in tachycardia. So ideally, in hypoxia, we need the tachycardia also, as well as the rise in BP. That is achieved through this indirect action. But the direct action of mild hypoxia is bradycardia. So remember, direct action is brady, whereas indirect action is tachycardia. But indirect action tachycardia is very, very essential, because whenever there is a severe hypoxia, we need to increase the heart rate as well as the BP of the person, so that the vital organ blood supply is maintained. Now coming to the CNS ischemic response, it is also a short-term regulation only, but this happens whenever the pressure drops down to very low levels like 50 or 20 mm of Hg, something like that. Whenever the pressure drops down to very low levels, what will happen to the blood supply of the brain? The blood supply of the brain will be compromised, definitely. So there will be hypoxia in the medulla. There is direct hypoxia in the medulla. So this direct hypoxia is a strong stimulator for RVLM. What is the RVLM's main function? All of us know that RVLM's main function is to increase the sympathetic outflow. And this sympathetic outflow will be so severely increased that it can raise the BP to 220 mm of Hg. So if the person is dying, this is the last thing that the body will do to raise his BP to supply the vital organs. That's why it is called last ditch stand. CNS ischemia response is called last ditch stand. But the only demerit here is it will be there for 2 to 3 minutes only. Before that, some outside intervention has to be done. Then coming to the other form of CNS ischemic response, that is Cushing reflex. If there is a raised intracranial tension and it is compressing the vessels and producing an hypoxia, then that reflex is called Cushing reflex. So CNS ischemic response can be due to any reason. The blood supply is not reaching the brain, it can be one reason. But here, if it is due particularly due to the raised intracranial tension, then it is called as Cushing reflex. So it will compress the vessels and RVLM will be activated. So there will be an increase in BP, which will in turn stimulate the cardiac inhibitory center and decrease the heart rate. If there is a severe rise in BP, what did we study? Rise in BP, there is a decrease in heart rate. So this action will be indirect action, not the response. So first thing is there is an increase in BP because of the direct stimulation of RVLM. Because of the high BP, there is bradycardia. Because increase in BP will be sensed by the baroreceptor and will cause bradycardia. Here it is happening reflexly. That's why it is called reflex bradycardia. Not only that, the respiratory centers also will be stimulated and there will be irregular respiration. So this is the classical triad for Cushing, which you have to remember. So this could be a potential question. So irregular, so first is rise in BP. Because of the high BP rise, there will be reflex bradycardia followed by irregular respiration. So these are the important things. So coming to the heart sounds, S1 is due to the AV valve closure and it corresponds with the carotid. For example, when you want to identify S1 and S2, you place a stethoscope and place one hand on the carotid. Whichever is corresponding with the carotid, that is the S1, and the other beat is the S2. So S2 is nothing but a semilunar valve closure, aortic and pulmonary. S3, I told you, it is due to rapid filling, and S4 is due to the atrial contraction, which we have already discussed. So why we should know this? Because any event that is happening between S1 and S2 is the systolic event, and any murmur that is happening in this region is the systolic murmur. In a similar manner, from S2 to S1, it will cause the diastolic murmur. So this you will read it in medicine, which are the systolic and diastolic murmurs. So coming to the physiological process, there is splitting of S2. Most of the time, S1 is almost heard almost always with a single sound. But S2 there can be a slight split in the S2, A2 and P2. So let's try to understand when this physiologically happens. How does this A2 and P2 is happening? Is there any reversal of splitting happens? So let's see. So what happens during normal expiration? Expiration, whenever we are doing, there will be S1 and S2 also will be heard normally. But during inspiration, whenever we take an inspiration, the chest cavity is expanding and all the vessels are having the space. So there will be an increase in venous return to the right side of the heart. So this is nothing but the right side of the heart. So more and more blood will be filled in the right side of the heart. So when emptying happens, what will happen? More venous return is there in the right side. So the P2 is nothing but the pulmonary valve closure. So will it take less time or more time? Now more blood has to be emptied into the pulmonary side, pulmonary veins. So, so what will happen? Pulmonary artery. So more blood has to be emptied into the pulmonary artery. So it will take more time for the closure of the pulmonary artery. So again, there will be a splitting. There will be splitting during inspiration because of the increase in venous return. So this is called as a normal splitting. Normal splitting happens during inspiration. We generally don't see a splitting during expiration. Now there is something called as fixed and wide split. The splitting size has increased and it is fixed. When does it happen? When does the splitting size can increase? The splitting size will increase whenever there is a delayed closure of the P2, like the pulmonary valves are closing at a delayed rate. When does it happen? Is it happens in a particular disease called as atrial septal defect. So what happens in atrial septal defect is whenever there is more blood on the left side, it will be passed on to the right side and there will be more blood here. In a similar manner, during inspiration, there will be more blood coming here, but again due to pressure equalization, some of them will go to the other side. So every time, whether during inspiration or during expiration, there is excess blood received in the right atrium. But at the same time, the amount is same. Why the amount is same? Because whenever the pressure on the right side is more during a venous return or an inspiration, it will go to the left side. Still more volume will be coming here also, but some of them will be going to the left side because of pressure equalization. And whenever the person is taking an expiration, at that time, more volume will be on the left side, which will be sent here. So the pressure will be equalized. Because of this ASD, that is the atrial septal defect, the pressure is getting equalized both during inspiration as well as during expiration. That is the reason there is fixed wide split. This fixed wide split, this is the classical example, and this can be a potential MCQ question. Fixed wide split, you remember ASD. Now coming to the wide but not fixed. So basically what is happening? There is a wide. So P2 is happening delayed. So P2 is happening delayed. What could be the reason? P2 will happen delayed whenever the right ventricle has more volume or the right ventricle is pumping slowly. So what could be the reason? Ventricular septal defect, what happens? More blood from the left ventricle will come to the right ventricle. There will be an increase in volume. Or pulmonary regurgitation. In pulmonary regurgitation, what will happen? The pulmonary valves are not functioning well, so more and more blood will enter. So there is increased delay in the P2. Or right bundle branch block. In right bundle branch block, the right ventricle cannot pump faster, so there will be delayed pumping and there will be delayed closure of the P2. Reverse splitting. Reverse splitting means here P2 is coming first, A2 is coming second. Whenever there is a failure of, whenever there is an increased load on the right side or the right ventricle is not pumping, we got a splitting like this, which is not fixed. Here in reverse splitting, what will happen? There should be a problem with the left side. Either there is more volume on the left side or the left ventricle is not pumping well. So when does it can happen? It can happen whenever there is an aortic regurgitation. Aortic regurgitation, what will happen? More and more blood aorta will regurgitate into the ventricle. So during the next contraction, it will try to push this blood and there will be a delay in the closure of A2 because the blood is being constantly pumped. Again, in left bundle branch block, what will happen? There is again a delay because left ventricle will contract slowly. So there will be more time taken for the blood to be ejected. So aortic valve will close a little later. So A2 will come reverse. So
sir, please explain fixed and wide, sir.
Fixed and wide. Okay. In fixed and wide will happen in only one condition, that is the atrial septal defect. So what happens is here is there is an ASD, so there is a space here. So what happens here? Normally during expiration, it is said that the left side will receive the more blood. Okay, left side not during inspiration, expiration we are talking about. So this more blood can come here, okay, and this will fill the ventricle more. So first thing that will be happening is it is wide. Then it will make it wide. Why? Because now I have to eject more blood for a longer time. So it will make it wide. Second thing, what will happen is During inspiration, again more blood is coming here, but the pressure on the right side will be more, correct? You are here till now. But again, this valve is open. So
Okay,
what will
sir.
happen? It will send some of the blood here, but still a larger volume will be available. Okay, but some of whichever ideally we expect a more wider thing during inspiration. Now that will not be more wider because the pressure from here will push the blood there, some of the blood. Okay, so both the time it will be wide, but it will be fixed because this ASD or this atrial septal defect, it is equilibrating the pressure both during inspiration as well as during expiration. Is it clear?
Thank you, sir.
Okay, thank you. It's a little difficult concept only, but I would suggest you to just understand it once and come back to the summary. Okay, summary: normal split during inspiration, wide and fixed. Just remember ASD. Wide and not fixed will be the defect from the right side. Sorry, wide and not fixed will be defect from the. It should not be VSD here. Just a minute. Wide but not fixed will be a ventricular septal defect, so that right side volume should be more, or a right bundle branch, or a right side volume can be more with the help of pulmonary regurgitation or a pulmonary hypertension. In pulmonary hypertension, again, what happens? There is severe pressure here. There is an increased pressure here. So more time will be taken for the right side to send blood into the pulmonary artery, and there will be delayed closure of the pulmonary valves. Then comes the reverse splitting. Reverse splitting, when it will happen? Either the volume in the left ventricle should be high, or the left ventricle should take longer time to pump the blood. When can the left ventricular volume be high? Whenever aorta is putting more blood back, or there is a left bundle branch which is pumping slowly, or a systemic hypertension due to which the heart is pumping slowly and it is taking more time for the A2. So A2 will come delayed than P2. So P2A2, that is called as a reverse splitting. So this is all about the normal heart sum splits and some abnormalities. Coming to the ECG. So ECG, all of us know, it is the electrocardiograph or electrocardiogram. It is identified by Willem Einthoven. It is just a surface recording. We are not putting the leads into the heart. That's why it's called surface recording. And how we are able to record the heart electrical activity in the outside, because our body is a volume conductor. For example, that's why we get current shock also. Whenever you touch the electrical current, we are getting a shock because our body is conducting. In a similar manner, the heart, which is producing the pacemaker potential, that will be conducted to the entire body, which we are able to record it from the surface. So generally we do a 12 lead ECG. Out of this, the 3 will be the limb leads, which are called as the bipolar leads, because it will be taking potential difference of the two sides. And 3 augmented leads, it will be computed by the machine itself. We don't put any leads. Whichever lead is already put there, it will augment it and give it. And 6 chest leads, which are called as the unipolar leads. So this is the setup. So bipolar leads means it records the potential difference. Unipolar leads means one of them will be connected to a high resistance and the other one will be an exploring electrode. Since there is only one exploring electrode, it is called as unipolar leads. And the group is horizontal leads are for the chest leads. There are 6 horizontal chest leads, and vertical leads are the limb leads plus the augmented leads. Vertically, we are recording the limb leads as well as the augmented leads. Horizontally, we are recording the chest leads. So coming to the limb leads, lead 1 is between the right arm and left arm. Lead 2 is between the right arm and left leg. Then lead 3 will be the left arm and left leg. So this is the connection, general connection, we generally do it. Then augmented lead. What is the function of augmented lead is they will amplify the signal, but they will not change any characteristics of the potential generator. For example, a wave is like this. Augmented lead, what it does is it will just amplify the lead in all dimensions. In all dimensions, it will not change any other. It will just show it in a bigger format. So what is the advantage? We can augment and read the ECG very easily. And how much augmentation is done? That could be the question. So augmentation is done 50%. For example, if 2 millivolt is recorded in one of the lead, what will be the augmented lead? A corresponding augmented lead. It has to amplify by 50%. 50% of 2 is nothing but 1. So total total recording will be 2 from the primary recording and amplification of 50%. So it will be 3 millivolt. So if they give the if they give the reading as 4, then what is the end recording? 50% of 4 is 2, add that. So it is around 6 millivolt. So we can calculate it easily. And coming to the chest leads, just I have given the placements. V1 to V6 is there, and V1, V2, V3, V4, V5, V6, and V5, V6, V4, V5, V6, all of them are in the fifth intercostal space. One is in the midclavicular, another one is anterior axillary, another one is in the posterior axillary line. Whereas V1 is placed in the fourth intercostal space on the right side, V2 on the fourth intercostal space on the left side. Then V3 does not have any proper position. It is between the V2 and V4. So these are the chest lead placements. That's all. And whenever we talk about an ECG recording, these are the primary waves we get, which is the PQRST waves. So out of this, the P wave is created by the atrial depolarization. And the PR segment is created by the AV nodal delay. Whenever from the SA node, it is firing and reaching the AV node, in the AV node, there will be delay. Then the AV node will keep the impulses with itself. So that will produce a straight line. So that is the PR segment. Then the QRS complex is made up of three different components. All of us know that QRS complex is due to ventricular depolarization. But I would suggest you to read individually. Q wave is due to the septal depolarization, ventricle only, ventricular septal depolarization. Then R wave is particularly due to the major ventricular depolarization, and S wave is due to the basal parts of the ventricular depolarization. So ventricular, if it is there, so septum is getting depolarized like this. Then the major ventricle will get depolarized, and finally the basal regions will get depolarized. So these are the three different forms of the same ventricular depolarization which happens. That's why we get three different waves. Then when entire ventricle is depolarized state, there will be no current flowing through it. So that will produce the ST segment. Okay, that will produce the ST segment. After that, the repolarization wave, which is called as the T wave, is given by the ventricular repolarization. So these are the waves that most of us know from beforehand only. And coming to the ECG paper, this value will help us to understand or calculate the heart rate. First thing is it has got an x-axis and y-axis. In the x-axis, the paper is running at the speed of 25 millimeter per second. So, and all the small boxes are around 1 mm. So how will we calculate it? So it is around 1 by 25, which is nothing but 0.04 seconds. So every single box will be crossed by the crossed in the ECG paper around 0.04 seconds. In a similar manner, in the y-axis, we have the amplitude calibration, which is around for every 10 mm, there will be 1 millivolt deflection. So the smallest box is 1 mm, which will give 1 by 10. Since 10 mm is giving us only 1 volt, 1 by 10. So it is around 0.1 millivolt. So for every, if you take an ECG smallest square, its x-axis is around 0.04 seconds, whereas its y-axis is around 0.1 millivolt. So this will help us to calculate it. For example, if any wave has gone through 3 boxes, it has covered 3 boxes, let's take, then its duration will be 0.04 into 3, that is equal to 0.12 seconds. In this manner, we can calculate it. And they will ask you to calculate the heart rate. How will you calculate the heart rate? We know the paper speed. Obviously, it is very simple. Paper speed is around 25 millimeter per second. And heart rate is calculated for 1 minute. So this paper would have traveled 150 mm per minute. And if I know one heartbeat's duration, I will know in this 1500 millimeter how many heartbeat has been transported. So one heartbeat, I can take any area, any region which should correspond. For example, if I take the P wave height, I should correspond it to the P wave height. That is one heartbeat. But which is preferable? RR interval. The RR interval is preferred because they are tall and easily visible in the ECG. So this will give us the one heartbeat. So what is the formula? It is 1500 divided by number of small boxes between RR intervals. So if they give an ECG mission and ask you to calculate an heart rate, this is how we can calculate 1500. 1500 came from the paper speed and divided by number of small boxes between RR. Why we take RR? Because that gives a one heartbeat. And the cardiac axis, normal cardiac axis, we should remember it is minus 30 to plus 100. Some books write plus 90 also. It's around that range, minus 30 to plus 90 or plus 110 in that range. Then clinically, some of the very key important ECGs I will just brush up through here. So first is the Wolff-Parkinson-White syndrome. As you can see here, the SA node starts here and it comes to the AV node. The AV node keeps the impulse. So in Wolff-Parkinson-White syndrome, what is the pathology? The pathology is in the additional one more fibers are connecting the atrium and the ventricle. For a normal person, the connection between atrium and ventricle is just the AV node. It's only the AV node. But here what happens is there is an additional connection. So the P wave will be produced. There should not be any problem in the production of P wave because it is happening here. But the AV nodal delay, which is responsible for the PR segment, will that be produced? It will not be produced. What is the reason? Because whenever the impulse reaches here, it will not cause any delay. This bundle will directly transmit the impulse here. So the PR interval, which is produced by the AV nodal delay, will not be there because the AV nodal delay will be there, but some other person is conducting through other route. So the PR segment will be shortened as shown in this diagram. So the PR segment is shortened. Now from this bundle of Kent, some of the impulses have come. So they have already started charging the heart. After the delay, what will happen? More and more impulses from the AV node also will come and join. So what will happen is there will be a huge wave like this. There will be huge wave like this. And this elevation, as you can see here, pointed here, is called as the delta wave. So what is happening? The PR segment is shortening because AV nodal delay time is being occupied by the bundle. So PR interval is shortening. There is a presence of delta wave and the QRS complex looks widened. So these are the three features of the Wolff-Parkinson-White syndrome. Try to remember all these three features. Now coming to the conduction block. Conduction block means the conduction pathway, that is from the SA node, there is some block which is happening. So it is generally divided into three different conduction blocks: first degree, second degree, and third degree. The first degree, I'll tell you, first degree, there is no actual block. To be true, there is no actual block. It is just the PR interval prolongation. The PR interval is just being prolonged. And how much prolongation is there? The normal PR interval covers three boxes. Three boxes is 0.12 seconds to maximum of 0.16 seconds. If it exceeds more than 5 squares, that is 0.20 seconds, then we call it as first degree heart block. First degree heart block, please remember, you should always look for the prolongation of PR interval. Nothing else will be there. There will be no drop of QRS, no affected QRS, nothing will be there. It is just the PR interval which will be prolonged. It is actually not a block, to be true. A second degree heart block is called, second degree heart block is further divided into Mobitz type 1, Mobitz type 2. What is Mobitz type 1? In Mobitz type 1, what happens is, ideally in heart block, what should happen? All the impulses from the SA node should not be conducted to the ventricle. That is the key. That's why we call it as a block. Here what happens is, there is a constant prolongation of PR interval. Finally, there will be a drop in QRS. As you can see here, there is the QRS is not coming after. But here the pattern is more important. The pattern is more important is you should look for the PR interval prolongation. As you can see in this diagram, it is keeping on prolonging with every beat until a QRS is dropped. So it is prolonging the PR interval and finally dropping a QRS complex. If this pattern is seen, it is called as Wenke-Bach phenomena or second degree heart block type 1, Mobitz type 1. So that is the term used. In Mobitz type 2, what is there? There is drop in QRS complex anytime it can happen. There is no particular pattern. There is no PR prolongation. That will not be there. The PR will be same. The PR interval will be same. But suddenly, for every 3 beat, maybe 2 QRS complex can come. That is called 3:2. Then 2:1. Those kinds of pattern will be there. Like 2 PVRs will be there, 1 QRS will be there, 1 would have been dropped. 3 PVRs will be there, 1 QRS can be there. There can be multiple patterns, but there will not be prolongation of PR interval. If there is a pattern which shows a prolongation of PR interval, suddenly a drop of QRS complex, then that is Wenke-Bach phenomenon. Coming to the third heart block, it is pretty simple. No impulse from the atria is coming to the ventricle. So the atria is beating separately and ventricle is beating separately. I have already told you the atria can beat around 40 to 60 beats per minute and the ventricles can beat around 20 to 40 beats per minute. So they are beating on their own rate. There is no connection between them. Atria is beating separately, ventricle is beating separately. So that is called as a third degree heart block. It is also called as complete heart block. And coming to the myocardial infarction, there will be an STA segment elevation, and depending upon the location of the leads, we can get the wall. They'll ask you to identify the wall. For example, the inferior leads are lead 1 is going like this, lead 3 is also going inferiorly, lead 2 is going inferiorly, then lead 3 is also going inferiorly, and one more lead which goes inferiorly is the AV foot, augmented lead in the foot. So whenever all these 3 leads are affected, there is ST segmentation in 3 of these leads, that is an inferior wall MI. Laterally, which lead is going? Already limb lead, we know one limb lead is going here there, that is the lead 1. Lead 1 is going like this. Another lateral leads are V5 and V6. That's why I told you the location. Lead 1, V5 and V6 are lateral MI. Anterior wall MI is given by the topmost leads in the chest leads, that is the V1 and V2. Then V3 and V4, they give the anteroseptal, both the anterior part of the heart as well as the septal region. So this you try to remember. It is just you have to know the placements of the lead. Once you know the placements of the lead, you can identify in which particular wall it is affected. Then coming to the electrolyte imbalances. Electrolyte imbalances, again, always we study these 3 only. One is the sodium, calcium, and potassium. So usually the electrolyte imbalance of sodium will not deflect anything in the action potential. We know that. So obviously, a hyponatremia and hypernatremia, usually they don't change significantly over the ECG. Now, in hyponatremia, the waves are small. In hypernatremia, we don't find anything. There is no significant ECG changes. Then coming to hypocalcemia and hypercalcemia. What happens in hypocalcemia? There is a QT prolongation. In hypercalcemia, the reverse happens. There is shortening of QT. And if they give you one particular wave, which is the J wave, which looks something like this, or an Osborne wave, then that happens usually in hypercalcemia. It is very rare, but usually it might happen. But more than these 2, like hyponatremia and hypocalcemias, one is very important, that is the kalemia. Because kalemia, whether it is hypo or hyper, both of them are dangerous for the person, and both of them have the potential to develop into severe arrhythmias. Hyper, just remember, hyper means high. So there is a tall T wave. That is simple. And there is a widened QRS complex. And in hyperkalemia, there are more chances of atrial fibrillation. And I told you in fibrillation, it will be shaking. It is not producing any particular pattern. So the A wave, sorry, there will be an absent P wave. In atrial fibrillation, there will be an absent P wave. In atrial fibrillation, one more feature can happen, that is an absent A wave. Because the heart is just shaking. Fibrillation, the number might be very high. Fibrillation is around 350 to 500 beats, but it is just shaking. There is no productivity. So whenever it contracts only, I can produce an A wave. Whenever the impulses are traveling properly only, we can record a P wave. So there will be waves like this, which is called as fibrillatory waves, but no proper P waves will be there. That is in hyperkalemia. Coming to hypo, hypo means less. So there is a depressed T wave. T wave is the major one which is being affected. The reason being because potassium primarily is involved in repolarization mechanism. So in hyperkalemia, we see a tall T wave. In hypokalemia, we see a depressed T wave. Not only that, there can be an additional clue in hypokalemia, which is rare. There is a presence of an U wave. So this U wave might be there, which is due to some impulses in the Purkinje fibers. Then coming to tachycardia. Arrhythmias, both brady can be there as well as tachyarrhythmias can be there. Tachyarrhythmias means the heart rate is high, brady means the heart rate is low. There is something called as a sinus arrhythmia. What is sinus arrhythmia? During inspiration itself, the vagal discharge from the respiratory fibers, they will go and inhibit the cardio inhibitory center. If the cardio inhibitory center is inhibited, there will be an increase in heart rate. So whenever a person is taking inspiration, like every day, like whenever taking inspiration, there is an increase in heart rate. That is the sinus arrhythmia. Then there are 3 terms: atrial tachycardia, atrial flutter, and atrial fibrillation. Atrial fibrillation. What is the heart rate? Up to 220, it is usually referred to as, many books give many references. This is from Genom. Up to 220, it is called atrial tachycardia. 200 to 350, it is called flutter. And 350 to 500, it is called fibrillation. Here, these are not the P waves. They are called as fibrillation waves. There is no proper pattern like a P wave. This is the P wave. Here, there is no proper pattern. These are called fibrillatory waves. And sawtooth appearance. This will be the question. Sawtooth appearance will be seen in atrial tachycardia, flutter, and fibrillation. As clearly see this diagram, The sawtooth pattern, or the classical sawtooth pattern, is seen in flutter. Please don't write fibrillation for this. Fibrillation, those minute waves which happens in atrial fibrillation. So sawtooth appearance in atrial flutter. Remember this. Then ventricular tachycardia, the waves will be tall because of the ventricular musculature. So this is all about the ventricular tachycardia. So this is all about the cardiovascular system. Now we'll go on to the next system. That is the respiratory system. So respiratory system, CV and CV, central nervous system are the major system. After that, everything will have a less number of pages only. We can cover it. So coming to the respiratory system. So these are the topic lists for the respiratory system. So I have given a topic list so that whenever you want to read something, you will know where exactly it is positioned. So let's discuss, start with the anatomy of the respiratory system, functional anatomy. The respiratory system is divided into upper airway, then the conducting airway, and finally the alveolar airway. So conducting airway means there is no gaseous exchange. It is just conducting the external air to the inside. Whereas alveolar airway means it is exchanging the gas. So it is given by Weibel's classification. The name we should remember, it is given by Weibel's classification. And division number 0 is considered as trachea. In Weibel's classification, there is no 0, but the trachea is considered 0. Below trachea, we have 23 divisions. So 1 to 23. Out of this, the first 16 is the conducting. The rest 17 to 23 are the respiratory zone, because gaseous exchange can happen in this division zone. So that's why it's called respiratory zone. So coming to the alveolar epithelial cells. The alveolar epithelial cells are primarily classified into two. One is the type 1 and type 2. This type 1 is the maximum. So 95% of the surface epithelium is occupied by the type 1. Why? Obviously, type 1's function is for gaseous exchange. The most important function of the lung is for gaseous exchange. So majority is given to the type 1. Whereas type 2, its surface epithelium distribution might be less, but still it is very, very essential. It occupies just 5% of surface epithelium, but it produces two most important substances. That is antitrypsin, alpha-1 antitrypsin, and surfactant. Alpha-1 antitrypsin is very important because it is a serine protease inhibitor. It is made up of a serine protease inhibitor. What it does is it goes and attacks this protease, that is a neutrophil elastase. If neutrophil elastase is present, what it will do? It will go and destroy the pulmonary epithelium. So this serine protease inhibitor is destroying the neutrophil elastase and preventing the pulmonary destruction of pulmonary epithelium. And this alpha-1 antitrypsin will be deficient in smokers or congenitally. Smokers, if they constantly keep on smoking, their antitrypsin levels will come down. So what will happen? The neutrophil elastase will be very much available and they will damage the lung, and it will lead on to early onset emphysema. So this is the thing that can happen. Then coming to the next important substance, which is the surfactant. All of us know its function. It is to reduce the surface tension. But question does not stop there. You should remember it is 90% made up of lipids and 10% of proteins. Surfactant proteins, A, B, C, D are the names given for them. And the question is, what is the most common component which is involved, which is contributing to this surfactant? It is nothing but the DPPC, that is dipalmitoyl phosphatidylcholine. DPPC is the most important substance which is contributing to this surfactant. It is also called as lecithin. Sometimes they give the option as DPPC, sometimes they give it as lecithin. What is the major component? What is its function? It is to reduce the surface tension. And all of us know, whenever there is a increased surface tension in a newborn, especially a premature newborn, it is treated with the help of one drug, which is corticosteroids, glucocorticoids. So the surfactant amount is increased by the glucocorticoids, thyroid hormone, and TRH, that is the thyroid releasing hormone. Both are same because TRH is in turn increasing the thyroid hormone levels. So glucocorticoid, we have to remember, it is very, very important, and we will study the importance also. And it is decreased by high insulin. That is why whenever a pregnant woman is taking high levels of insulin, exogenous insulin also, it is little dangerous for the baby. And cigarette smoking. So mother cigarette smoking also will affect this surfactant levels, and as such the surfactant effect of the adult also will be affected by the cigarette smoking. And 100% oxygen inhalation. 100% oxygen inhalation again will reduce the levels of the surfactant. So if the surfactant levels are low, what will happen, especially in case of a newborn, it is called as infant respiratory distress syndrome. Infant respiratory distress syndrome, IRDS. It is also called as hyaline membrane disease because hyalinization happens. The lung looks like as if it is completely hyalinized. So it is a hyaline membrane disease. So in a premature infant, there is an immature lung. So if the infant is born already, what is the treatment? The only treatment is to give exogenous surfactant to the infant itself. But if the mother is having labor pains or we are planning for an early delivery of labor, then this can be prevented with the injection of betamethasone or dexamethasone. It is nothing but our glucocorticoids. Glucocorticoids can be given to the mother before delivery. But once the delivery is done, obviously it has to be given, surfactant has to be given directly to the baby. But for the mother, this glucocorticoids can be given as a prevention. Previously, we were giving it in 2 doses, but right now the guideline has been changed to 1 dose is sufficient. So coming to the mechanics of respiration. So that was all about the anatomy. Now coming to the mechanics of respiration, we have to understand one important law, which is called as Boyle's law. What does Boyle's law state? That the pressure is inversely proportional to volume. So this is simple law. So for example, there is a volume of water and we try to compress it. What will happen? Here the volume has reduced, but what will happen to the pressure? Now the molecules are closer, pressure will be increased. This is a simple experiment. Why this is important is because whenever we say the volume of the lung is increasing, there is a drop in pressure. I will be mentioning this. There is a drop in pressure. We should understand how this drop is happening because of this equation only. And this is the primary diagram which will be shown. The innermost part is the alveoli, and the pleura, which is just surrounding the alveoli, is the visceral pleura, and surrounding that is the parietal pleura. So this is the intrapleural space and the chest cavity outside in the outer region. So what is intrapleural pressure? Intrapleural pressure, it is the pressure in between the two pleural cavity. One pleura is attached with the viscera, that is called the visceral pleura. Another one is the parietal pleura. What is the property of lung and the chest wall? Because we have to understand, because visceral pleura is attached to the lung, whereas parietal pleura is in connection with that of the chest cavity. So once we understand the property of lung and the chest cavity, we can understand what is the pressure that can be created by this in between these two. The lung property, it is elastic recoil, it is to collapse. So the lung will create an inward movement. The lung is trying to create an inward movement, whereas chest wall cavity, its property is to expand out. So it is creating an outward movement. So it is creating an outward movement. So now one person is pulling in, one person is pulling out. So what will happen? There will be an increase in volume. There will be an increase in volume. So already we have said that whenever there is an increase in volume, what will happen to the pressure? Volume increases, there is a decrease in pressure because now more volume is available. So this is the reason, because of the volume increase that is constantly happening, the pleural pressure is always low, and we can say that it is always negative. Until and unless it becomes pathological, it is always negative. The pleural pressure is generated by the opposing forces of the lung and chest wall. Lung is pulling in, chest wall is pulling out. Because of these opposing forces, we are creating a volume increase and pressure drop. And it is maintained by the lymphatics, created by them, but maintained by the lymphatics. And I told you it is always negative. So the starting point at rest itself, it is around minus 2.5. That is the reason why we are able to pull in the air. So what happens during inspiration? We are expanding the lungs, so the volume is increasing more and more and more. The volume is increasing more and more. So there will be pressure drop up to a certain point. After that, during expiration, what will happen? Again, the volume is decreasing, the pressure will keep on increasing. So it revolves between minus 2.5 to minus 6, again to minus 2.5. So it keeps on revolving around during inspiration and expiration. So this is the intrapleural pressure in between the pleural space. Now coming to the intraalveolar pressure. Intraalveolar pressure is also called as the intrapulmonary pressure. So alveoli is directly connected with the atmosphere. So whatever is in the atmosphere, that will be the alveolar pressure during rest. That is 0 mm of Hg. What happens during inspiration? During inspiration, the alveolar is getting expanded. So what will happen to the pressure? The pressure will come down. So during inspiration, the pressure will come down. But during inspiration itself, once inspiration has happened, now more and more air will enter. More and more air will enter, increasing the pressure. So at the end of inspiration, again, if the air has entered, then it will go back to 0. Then during expiration, the reverse happens. What happens? First, there is a collapse. So there will be an increase in pressure, and when air goes out, the pressure comes back to 0. So the baseline will be 0, end of inspiration will be 0, end of expiration will be 0. And it is least during the mid inspiration. So mid inspiration, it is -1, it is least. It is maximum during mid expiration, that is +1. So this is the range between the alveoli, because the alveoli is directly connected with the atmosphere. Whereas it is always negative in case of it never goes to positive in case of intrapleural pressure until there is a pathology. Let's try to understand what is the pathology. So the pathology here is pneumothorax, that is the presence of air in the pleural space. More than pneumothorax, there is something called as tension pneumothorax. Tension pneumothorax, what happens is there is formation of a one-way valve in the intrapleural space. So whenever the person is inspiring, the air is going out. Whenever the person is expiring, this valve is getting closed. So what will happen? Air starts to build here. Air starts to build here. But during next inspiration, again air will go in, more and more air will be settled. So air starts to build up again here. So what will happen to the pressure? From -2.5, it can go to the positive pressure also. What is the disadvantage of positive pressure? Whenever it goes to a positive pressure, it can collapse the lung. So there can be a sudden collapse of the lung. So any patient, whenever they come to you and you suspect a tension pneumothorax, the first thing, ideally we should do an ICD, that is a treatment, intercostal drainage should be done. But first thing that we should do is puncture in the second intercostal space. That is the first line of treatment. If they ask you what is the first line of treatment, choose this option using a wide bore needle. And for checking it, usually generally in a government setup, we always put the tube into the water. If it is bubbling, it means that we are in the right space and the air is being, because we have to take out the air from here. Otherwise, it will keep on collapsing the lung and the lung will be completely collapsed. So this is a medical emergency condition. Okay. So coming to the next concept, that is the lung volumes and capacity. We are going to discuss them in static as well as dynamic. So static means we are not going to take into time factor into account. Whereas dynamic, when I use the term dynamic, there time factor will be taken into account. So static means simple static values that we measure using a spirometry. All of us would have used this spirometry, wherein they will be doing an experiment to record the lung volumes and capacities. So let's talk about the volumes. So the procedure goes like, we'll take normal inspiration, then we'll ask subject to take a deep inspiration, followed by normal inspiration, then deep expiration. Then we will ask them to do both of it at the same time. So we'll get a recording something like this. The normal inspiration and expiration done, that is called as the tidal volume. And above the tidal volume, whatever reserve or extra I can take in, that is called as the inspiratory reserve volume. In a similar manner, from the tidal volume, whatever expiration extra that can be done, that is called as the ERV or the expiratory reserve volume, because they are in reserve. Normally we are not using them. As and when we require, like in a bike also, normally we put it into reserve whenever it is required. So that is the inspiratory reserve volume, expiratory reserve volume. And one more volume is there which cannot be measured by a spirometry, that is the residual volume, because spirometry will record whatever volume is coming out. Residual volume always stays inside the lung, so it cannot be measured. So tidal volume is the normal volume of air breathed in and breathed out. It is around 500 ml. These are the new values given in Geno. So try to remember the new values. Second thing is inspiratory reserve volume, the extra amount of air above the normal inspiration. So it is 2000 ml. Previously it was written 2000 ml to 3000 ml, but right now they have given 2000 ml. Then expiratory reserve volume is around 1000 ml. Then residual volume. Even after forceful expiration, whatever air remains in the lung is the residual volume. Its value is around 1300 ml. These are the 4 volumes, and out of this, the residual volume cannot be measured by a spirometry. It cannot be measured by a spirometry. Then coming to the 4 capacities. There are 4 capacities. Whenever we add up some of the volumes, we get the capacities. So if the tidal volume is added along with inspiratory reserve volume, it is called as inspiratory capacity. Then after normal expiration, we have done whatever air is there in the lung remaining, that is called as a functional residual capacity, because after the normal function, it is occurring in a residual level. Okay, that will have the expiratory reserve volume, because normally we are not throwing it out, as well as the residual volume. Then we ask them to take a deep inspiration followed by a deep expiration. That will give us the vital capacity. Here we call it as vital because this is the maximum amount of air that I can exchange with the atmosphere. Because I am taking the maximum possible in and I am taking the maximum possible out. So in case of an emergency situation, we can use this vital capacity to its fullest capability. And finally comes the total lung capacity, like addition of all of them. Whenever we add vital capacity with that of the residual volume, because residual volume is not exchanged out, it gives us the total lung capacity. Again, the calculations are given. Inspiratory capacity is 2500, functional residual capacity is 2300, vital capacity is 3500, total lung capacity is around 4.8 liters, 4800 ml. So these are the lung volumes and capacities. Out of this, wherever residual volume is there, that we cannot measure it. For example, yeah, we have the normal residual volume and functional residual capacity. We have the expiratory reserve volume plus residual volume. So I cannot measure this. Plus next thing is TLC. TLC will also have the residual volume. So wherever residual volume is there, I cannot measure them with the normal spirometry. We need instruments like body plethysmography to measure them. Body plethysmography is the best method to measure the residual volume as well as the functional residual capacity and total lung capacity. So this is all about the lung volumes and capacity. Static. Now we are going into the dynamic part. So dynamic part means I will take the time factor into account. For example, we will calculate what is the volume that is expired in 1 second, what is the volume that is expired in second, then third second. So here we will have the time factor. We will ask them to forcefully expire and we'll try to find out how much percentage has come out in the first second, how much percentage has come out in the second second. Like that, we will be doing it till all the volume. Same procedure only. We will ask the subject to breathe in maximal and breathe out as fast as possible. Here the command should be fast and forceful. Whenever we are doing fast and forceful, then the time factor will be taken into account. Why it is very important is because FEV1 is around 80% of FVC. For example, the FEV1 by FVC is normally around 80%. And this ratio will help us to identify and differentiate between obstructive disease and a restrictive disease. So FEV1 by FVC is very, very important. So coming to the diseases, the obstructive disease as well as the restrictive disease. Restrictive disease, just remember, some part of the lung is restricted. So here the pathway is completely fine. The airway pathway is completely fine. Restrictive disease, please remember it as small lung. That will be very, very easy to remember. So small lung, just remember it is a small lung. Whereas obstructive disease, the lung parenchyma can be completely normal. Where is the pathology? I have drawn some black over here. As you can see here, there is a problem in the respiratory tract. So what are the examples? COPD, which includes emphysema and bronchitis, asthma, bronchiectasis, cystic fibrosis. All this will come under obstructive disease. Whenever the parenchyma is damaged and making it small, small means now don't think it is completely crushed. It is that only the half of like partial portion of the lung is replaced and rest of the partial portion is being unused. The interstitial lung disease, fibrosis of lung, then skeletal disease. Even a skeletal disease which is restricting the chest movement behaves like a restrictive disease. So this table is important to identify the differences between restrictive and obstructive. The total lung capacity will be normal because only the airway defect is there. But here I told you it's a small lung. So obviously the total lung capacity will be reduced. The FVC, forced vital capacity, if we are doing it forcefully, obviously this will be, both will be reduced. Here it is reduced because already the expected volume is, already the volume that is available for throwing out itself is less. Then FEV1, this is very, very important. The FEV1 is reduced a lot. What is the reason? Let's go back and see. FEV1 is, we are trying to expire it forcefully and calculating it the first second. Whenever you try to do it forcefully in case of an asthmatic patient, what will happen? There will be an obstruction of this passages because there is an edema fluid accumulation. They will obstruct it faster. So before this could be eliminated, the FEV1 is decreased a lot. Why? Because we are asking him to do it forcefully. Whenever he does forcefully, it will be obstructed very fast. So the FEV1 is reduced a lot. Here FEV1 is reduced, but not that much. In restrictive diseases, FEV1 is not reduced that much. So when we put a ratio FEV1 by FVC, the numerator is reduced a lot in case of an obstructive disease. So obviously the ratio is decreased in case of an obstructive disease, whereas the ratio can be normal or sometimes increased in case of restrictive disease. Why? Because here both V1 and FVC both are reduced proportionately, and sometimes the FVV1 reduction will not be that much because FVV1 depends on the air pathway, and air pathway is completely fine in case of an restrictive disease. So this is very, very important chart. We have to know it. Now coming to the anatomical and physiological dead space. What is dead space? Whenever something is not getting exchanged, the gases exchange is not there, it is like a dead space in respiratory system, because respiratory system, the only function it does is the exchange of gases, and some part is not doing it, we label it them as dead space. So in the conducting zone, always 150 ml is present. So this gas is not being exchanged. So out of the 500 ml, only 350 ml is available for gas exchange. Rest 150 is wasted because they are in the conducting zone. And there is this is the anatomical dead space, because conducting zone is never going to do any gas exchange. There is something called as physiological dead space. Physiological dead space includes both anatomical plus alveolar. For example, if any alveoli is not getting a proper blood supply, then also proper diffusion will not happen. That will create a dead space. Whenever I add the anatomical dead space as well as the alveolar dead space, that will give us the physiological dead space. But normally the alveolar dead space is almost around 0. So the anatomical dead space is equal to the physiological dead space in a normal person. But in a diseased person, this alveolar dead space can be increased to higher levels. Then comes the concept of ventilation perfusion ratio. What is ventilation perfusion ratio? Ventilation is nothing but the airflow. Whenever there is an airflow, that is called ventilation. And the perfusion means the blood supply. So the quantity of blood flow is the perfusion. And what is the alveolar ventilation? Please guys, if they tell you alveolar ventilation, it is not minute ventilation. Then what is minute ventilation? This is minute ventilation. Let's discuss. Minute ventilation means 1 minute how much ventilation is happening. So for example, 500 ml is the input normally, and the breathing rate is around 12. So 6000 ml is the minute ventilation. For every minute, we are taking 6000 ml in and out. But what is alveolar ventilation? Alveolar ventilation means, is all of 500 ml going to the alveoli? No. Or the gas exchange? The answer is no. Only 350 ml is going. So that is why whenever we multiply 350 into 12 to 14, it gives around 4 liter to 4.2 liter. So this is our alveolar ventilation. In alveolar ventilation, we have to exclude the dead space, because dead space is not getting ventilated. We have to exclude the dead space. So what is the normal ratio? Normal ratio is alveolar ventilation by the blood supply, which is around 0.8. But what should be the ideal situation? Ideal situation is 1. For example, airflow is there, the same amount of blood is being supplied and all the air is being extracted. But that ideal situation never happens in the human body. The ideal situation is 1, but normally we are getting around 0.8. Then there is some regional differences in the ventilation perfusion ratio, and this can be asked as a question. They can ask you the ventilation and perfusion, both are maximum in which part? I am not talking about the ratio, both are maximum in which part? As you can see here, the base region is more, and the number of alveoli present is here is more, and the blood supply that is going to the base is also more. So all these things are more in case of the base. So maximum ventilation is present, maximum perfusion is present. But VQ ratio, the blood supply in comparison to that of the ventilation is more. The denominator is more here. So the VQ ratio is least in case of the base. Whereas in apex, the alveoli are bigger and bigger. So what will happen to the ventilation? The ventilation is high in comparison to the perfusion. The perfusion is low. If the denominator is low but the numerator is high, what is going to happen to the ratio? The VQ ratio is going to be maximum, because the perfusion is very, very less in comparison to that of the ventilation. So we have to remember this point. Apex, ventilation perfusion ratio is maximum, but ventilation as well as perfusion, the quantity is maximum in case of the base. So coming to the next, the diffusion and perfusion limited gases. Please remember the names alone. Whenever any gas is reaching the alveolar level within the transit time. What is transit time? Transit time is the time duration through which the blood is passing through one alveoli. For example, if an alveoli is there and blood supply is passing through it, a column of blood is passing through it, the time that is spent in this contact period is called as the transit time. In this time, if it is equilibrated with the alveoli, for example, if it is reaching the pressures of the alveoli, even if the blood stays there for a longer time, the same blood stays there for a longer time, will there be any additional amount of gas that can be passed? The answer is no. So these type of gases where you need a new perfusion to take in more. For example, let's take an oxygen. Oxygen is completely going into the alveolar level at 0.25 seconds itself. It is very fast. 0.25 seconds itself, it is reaching the alveolar levels. After that, it is staying constant. So these kinds of gases, they need a new perfusion to take more and more oxygen. So these gases are called as perfusion limited gases. So what are the examples? O2, CO2, then nitric oxide. So all this are the perfusion limited gas. Please remember only one gas for diffusion limited. Diffusion limited. The diffusion capacity in lung itself is measured by this gas, that is called as diffusion lung capacity, CO. CO is carbon monoxide. As you can see here, even after the complete transit time, the alveolar levels are not reached by the CO diffusion. So that is why it is called as diffusion limited gas. Diffusion limited gas. I can give more CO to the same column of blood if I increase the diffusion capacity. For example, we try to make the membrane thin. If the membrane is thin, the same column of blood can carry more CO. But for your exams, please remember this diffusion limited gas, it is just the DLCO, the carbon monoxide, rest everything is the perfusion limited gases. So coming to the transport of oxygen is pretty simple. From the air, it has to reach to the tissue. So in the air, the barometric pressure is around 760 mm of Hg. Out of that, 21% is the oxygen. So when you multiply it, it brings to the atmospheric levels of 160. But all this 160 will not be available to us because we have to add some water vapor to it. Otherwise, the tissues, the respiratory epithelium will get burnt. So 47 mm of Hg is the normal water vapor pressure. So we have to subtract this. So 713, out of the 713, 21% is around 150. So the inspired air is around 150 mm of Hg. Whenever it goes to the alveoli, there some consumption happens because of the carbon dioxide exchange also. So the consumption happens and it brings the alveolar level to 100 mm of Hg. And we know that the pulmonary system has dual blood supply. One is getting oxygenated and the bronchial arteries, they don't get oxygenated. They will come and directly mix in the venous system. That is called as the venous admixture. This concept you will again study in anatomy also, venous admixture. Because of this venous admixture, this 100 mm is further reduced to 95 to 98 mm of Hg. When it reaches the tissue, the partial pressure comes down further because oxygen is utilized and it further comes down to 40 mm of Hg. So these are the pressures. You don't have to worry about the pressures that much, but transport form of oxygen is important because it has been asked in recent MRBs. First thing is the dissolved oxygen and hemoglobin bound oxygen. So the dissolved oxygen is very, very little. The percentage of dissolved oxygen is just 1 to 3%. Rest 97% it goes into the hemoglobin bound oxygen. But please remember one important thing about the dissolved oxygen. The dissolved oxygen is the one which is giving the partial pressure. So if I tell you the oxygen is being transported at 97 mm of Hg, it is entirely given by the dissolved oxygen. That is why we don't want to carry oxygen in the dissolved form completely. Then the partial pressure will be very high. But in the bound form, it does not contribute to any partial pressure. In the bound form, what is the question usually asked is, what is the amount of oxygen carried by a particular gram of hemoglobin? If the question is asked simply like that, just multiply by 1.34 and write the answer. But other than that, if they want to ask more, 1 gram of fully saturated hemoglobin, pure hemoglobin, that is the purest form of hemoglobin, can carry around 1.39 ml of oxygen. but pure hemoglobin is not present usually. And 1 gram of fully saturated hemoglobin carries around 1.34. That's why I wanted you to choose this value and multiply. But again, even this fully saturation does not happen because the partial pressure is around 97 to 99. This can saturate around 97% only. So the ideal situation wherein 1 gram of hemoglobin carried in arterial blood is 1.29. But most of them will give the value that is multiplied by 1.34 or a direct question for 1.34 because that is the standard written in all the books. They don't usually consider this 97%. They consider this fully saturated. Hemoglobin is fully saturated. So when this 15 is multiplied by 1.29, it comes to around 19.5 ml. So 19.5 ml is carried by the hemoglobin, 0.3 ml is carried by the dissolved form. So total in general, the oxygen carried is around 19.8 ml of oxygen per 100 ml of blood. So whenever it goes to the tissue, it delivers the oxygen and returns back into the venous system. In the venous system, whenever the same calculation is done, it comes to around 15.2 ml. So when we take the subtraction of these two, for every 100 ml of blood, how much oxygen is given to the tissue? 4.6 ml is given to tissue. Please remember this 1.34 value for a fully saturated hemoglobin levels that can carry this much amount of oxygen. Coming to the oxygen hemoglobin dissociation curve, this is one of the oldest and the famous questions. So in an adult hemoglobin, we have 2 alpha and 2 beta. So if there is a hemoglobin like this, there are 4 chains, alpha chains are there and beta chains are there. Out of this, the oxygen can bind in all 4 spots. So basically one hemoglobin molecule can carry 4 molecules of oxygen. And it will be very, very difficult for the first oxygen to bind. If they are like friends, if one binds, then it will help the other, and these two people will help the third one, and they will help the fourth one. So the fourth oxygen will have the highest affinity. They will bind very rapidly with that of the hemoglobin. The oxygen hemoglobin dissociation curve basically tells us the relationship between the partial pressure of oxygen with that of the hemoglobin saturation. If I keep on increasing the partial pressure of oxygen, I can saturate more and more, obviously. But the maximum that is available for us is around 97 mm of Hg. But 100% saturation usually happens at 120 mm of Hg. That's why I told you there is a factor that is even in humans it is not fully saturated, only 97% is saturated. So in this, what happens is we have to understand one important concept which is called as the P50. What is P50? It is the PO2. It is the levels of PO2 at which hemoglobin is 50% saturated. When the hemoglobin is having 2 oxygen, that is 50% saturated, then the alveolar levels is called as the P50. The partial pressure of, so it is nothing but the P50 is nothing but the partial pressure of oxygen when hemoglobin is 50% saturated. So what is the value? We just have to remember the value. It is 23 to 26 mm of Hg. But more than this, right shift and left shift are very important. Let's try to understand the right shift and left shift. So for example, whenever the curve is shifted right, here, this is the normal curve and this is the right shift curve. What is happening to the P50? From here, this was a P50 for that. It is moving towards the other side. P50 is increased. What does it mean? I need more partial pressure to bind the same amount of oxygen. So what does it tell us? It tells us that the oxygen is freely moving from the hemoglobin. The oxygen is moving away from the hemoglobin. So this right shift indicates low affinity of hemoglobin to bind oxygen because we are giving away oxygen. So when do we have to give oxygen to the tissue? Obviously, normally also we have to give oxygen to the tissue. But this right shift completely happens whenever there is an increased demand in the tissue, like whenever you are exercising. So just remember this first example, exercise. With that, we can do a lot of other things. So whenever we are exercising, what will happen to the CO2 levels? Obviously, it will increase. What will happen to the H plus ions? It will increase. Sometimes increase in H plus ions will be given in the question as decrease in pH. That should be noted down. Then there is an increase in temperature. Not only that, the glycolytic end product, there is an increase in 2,3-DPG also. This 2,3-DPG will go and bind to the beta chain. this 2,3-DPG can go and bind to the beta chain and kick out the oxygen away. So these are the reasons where there is a right shift of the curve. Other than that, we have to remember the other reasons also: anemia, hypoxia, high altitude. Obviously, in hypoxia, the tissue should try to extract more and more. There is a right shift. In high altitude also, oxygen is very less, so it is trying to extract more. In anemia also, it is trying to extract more. So we need a right shift there. Then increase in growth hormone, thyroid hormone, androgens. So these are the reasons that we should know. So these are the 4 common reasons previously asked. Nowadays, they might ask these things also. So additional things we have to know. So this right shift happens due to Bohr effect, they say. What is Bohr effect? Bohr effect is whenever there is an increase in CO2 tension, there is a release of oxygen. Where does it happen? It happens in the tissue. Just now we saw whenever there is an increase in CO2, there is a right shift and release the oxygen. So the Bohr effect is happening in the, just remember, boring things happen in the tissue. Bohr effect happens in the tissue. Bohr effect happens in the tissue. A very similar effect will happen in the lung, which is called as a Haldane effect. We'll try to discuss them while discussing CO2 release. So coming to the left shift. In left shift, what is happening to the P50? It is decrease. If the P50 is decreased, what does it mean? With less pressure itself, I can bind and keep more oxygen. So hemoglobin affinity to the oxygen is increased. That's what left shift tells us. And the reasons, exactly all the reasons that are opposite to that of the right shift, like decrease in temperature, decrease in PuCO2, decrease in H plus, and decrease in 2,3-DPG. That I'm not writing down here. There are some special reasons which we should remember: fetal hemoglobin, stored blood, CO poisoning, methemoglobin, thalassemia. So we have to remember all this reason. In fetal hemoglobin, it is having gamma chain, which is having a more potential. In stored blood, there is a decrease in 2,3-DPG. In CO poisoning, it will go and bind very strongly with that of the hemoglobin. At the same time, it will not allow whichever oxygen is bound to it. For example, the molecule is there like this, and oxygen is bound to it. There are other 2 spaces where CO is bound. CO is very dangerous. First thing is it is taking the space of oxygen. Second thing is it will not allow this oxygen to be released from the hemoglobin also. That's why CO poisoning is like that. Then other than that, methemoglobin and thalassemia, you have to remember where there is a left shift of the oxygen hemoglobin dissociation curve. Now coming to the transport of CO2. CO2 is transported in 3 different forms. Oxygen only 2 forms. One is the dissolved, another one is the with the combination with the hemoglobin. CO2 whereas 3 forms: bicarbonate, carbaminoform, and dissolved form. All 3 forms. Bicarbonate is the maximum form that is being utilized. In CO2 uptake, we have to start from the tissue and go into the lung. So in the tissue, the partial pressure is around, in the tissue, the partial pressure created is around 45 to 46 mm of Hg. Whereas in the arterial side, it is around 40. So from the tissue, it will come to the arterial side, like in the venous end. And while coming in the arterial side, they will carry around 48 ml of CO2. Here we have to add more. It comes to around 52 ml of CO2. So for every 100 ml, how much is added? 4 ml of CO2 is added per 100 ml. Okay. It is added here, and from the venous side, it is traveling. So if oxygen is delivered, the CO2 is being released. So the CO2 will come into the interstitium. From the interstitium, it will go into the plasma, and then finally to an important cell, that is the RBC. In the RBC, what will happen? CO2 will combine with H2O and form the H2CO3 with the help of an important enzyme that is called as carbonic anhydrase. And this speeds up the reaction. That is very important. It speeds up the reaction to 5,000 times. That is why RBC is very, very essential for even for the CO2 transport. It's not only the oxygen transport, CO2 transport also is very, very important. Then this H2CO3 will get converted to H plus and HCO3. This HCO3 will be sent into the plasma with exchange of chloride. This is called as chloride shift. It is also called as Hamburger effect. And this channel is called as anion exchanger. All are important. Exchanger. Chloride shift, Hamburger effect, or anion exchanger. Why it is called anion exchanger? The answer is pretty simple. Because one bicarbonate is coming, which is an anion, for a chloride, which is again an anion. So there is an exchange between bicarbonate and chloride. So that is why it is called as an anion exchanger. So all these things will happen. So in the plasma, we have lots of bicarbonate to be carried away. So in the lung, I have to go and throw this carbon dioxide. So what happens is, if it is a hemoglobin bound CO2, then definitely whenever oxygen comes and bind, the CO2 will be released easily. But major form is the bicarbonate form. So what happens again here is, bicarbonate should be sent back into the RBC again. And this is called as reverse chloride shift. And this is called as reverse chloride shift. And again the same reaction, bicarbonate is being sent into the RBC. Already we have seen that this H plus is there, which is produced in the bicarbonate. They will combine with hemoglobin, HHB. So now what happens here is, this HHB, whenever oxygen is there, in the presence of high oxygen tension, the H plus will be released, because HB will go and bind with the oxygen. Oxygen will go and bind with the HB. Now this H plus is available, and because of reverse chloride shift, we have brought in the bicarbonate also. And so they will form H2CO3, which can get converted to H2O plus CO2, and CO2 is released. Now I told you Bohr effect happens in the tissue, another effect happens in the lung. This effect is called as Haldane effect. What is happening here? Whenever high level of oxygen is available, there is a release of CO2 from the hemoglobin. So this is nothing but called as the Haldane effect. Due to high oxygen tension, boring things happens in the tissue. Just remember, Bohr happens in the tissue. There is too much of CO2, which is releasing the oxygen. Here there is availability of more oxygen, which is releasing the CO2 into the atmosphere. So this is the Haldane effect. Now coming to the regulation of respiration. Regulation of respiration is again important. The neural control, chemical control, and non-chemical control. Here the neural control and chemical control are very, very important. So coming to the neural control is the one which is generating the respiration, because normally none of us know that we are taking inspiration and expiration. It is happening automatically. So in the neural control, involuntary is the most important part. But if I ask you people to hold your breath or breathe faster like this, you will be able to do both of it. Why you are able to do both of it? Because it is controlled voluntarily also. Involuntary is very important, but sometimes it can be controlled voluntarily. But can this voluntary can happen forever? It cannot happen forever, because if I ask you to hold your breath also, at some point of time there will be too much accumulation of CO2 and you will start breathing yourself. So involuntary is the most important one. Let's try to discuss the voluntary first. The voluntary happens because of the cerebral cortex. The cerebral cortex, through the corticospinal tracts, they will directly influence the respiratory neurons, which in turn influences the respiratory muscles. And there is an important curse called as the Ondain's curse. In Ondain's curse, what happens is, there is a water nymph which gets married to a king. It's actually a mythological story wherein a water nymph gets married to a king, and she gets a promise that whenever she is leaving again into the water nymph is nothing like a mermaid, sea mermaid. When she leaves back again, she should not marry somebody. But the king marries someone, and this water nymph curses the king, telling him that the voluntary control will be present. In this person, what happened? In this person, voluntary is absent. So voluntary control cannot go forever, and especially when the person is trying to go for sleep, they will always require involuntary control of respiration. So when this king was, due to sheer exertion, he tries to keep himself awake, but due to sheer exertion, he finally goes into sleep and dies. Because in this person, the voluntary control is only present. So Ondain's curse is an example of only voluntary control present, involuntary is absent. So coming to the involuntary control. Involuntary control happens in the brainstem region, both in the medulla and the pons. In the medulla, there are very, very important centers. In the medulla, we have the DRG, that is dorsal respiratory group of neurons, and the VRG, ventral respiratory group of neurons. And in the pons, we have the pneumotaxic center and the apneustic center. Let's try to understand what are the functions of each of them. So first, coming to the DRG. DRG is the one which is involved primarily in the inspiration part. It is the one which is generating the inspiratory ramps also. They will integrate the information from all the respiratory centers, and its primary function is inspiration. And all of us know expiration is a passive process. So this VRG's main function is expiration, but expiration being passive, whenever the requirement is done forcefully, somebody has to inspire and expire forcefully, then only the VRG will come into play. Other than that, VRG is completely quiet. So it is involved in forceful inspiration and expiration. There is one more important complex we have to remember, that is the pre-Botzinger complex, which is generating the respiratory rhythm, and that is why it is called as the pacemaker of respiration. Like an essay note, it is a pacemaker for respiration, which is called pre-Botzinger complex. Coming to the ponds. Ponds we have already studied. One is the apneustic center, another one is the pneumotaxic center. As the name indicates, what is apneusis? Apneusis means the person is going in for a stoppage of breathing. So this apneustic center is present in the lower pons, and it will keep on doing the inspiration. So if the person is keeping on inspiring, is it good? Obviously it's bad, and it will produce an apneusis. So that is the reason why this apneustic center has to be controlled by somebody. So who is controlling this apneustic center? The apneustic center will be controlled by the pneumotaxic center. It will limit the inspiration of the apneustic center and switches from inspiration to expiration. So from inspiration, it will cause the expiration. So it will act like a switch between inspiration and expiration. That is the function of the pneumotaxic center. Coming to the chemical control of respiration, there are several chemicals which are involved: O2, CO2, and H+. These are the three major chemicals which are involved in chemical control of respiration. So in chemical control, we have the chemoreceptors. Because they are sensing chemicals, these are called as chemoreceptors. Chemoreceptors, again, we have centrally placed chemoreceptors and peripherally placed chemoreceptors. The centrally chemoreceptors are located in the ventral surface of medulla, whereas peripheral chemoreceptors are located in the carotid and aortic bodies. In the central chemoreceptors, one funny thing happens is the central chemoreceptors, they can get activated by H+, but H+ cannot cross the blood-brain barrier. But all of us know that H+ can be indirectly produced with the help of carbon dioxide. So this carbon dioxide instead goes in and forms the bicarbonate and the H+. So this H+, again the same reaction, CO2 plus H2O gives H2CO3 and H+ is formed. So they will stimulate the central chemoreceptors. So if the question is asked, which of the following ions stimulate the central chemoreceptor? It is stimulated by H+. But what changes is more important? CO2, because CO2 only can enter the central nervous system because of the presence of blood-brain barrier. So it is sensitive to what changes in the blood? It is sensitive to PCO2 changes in the blood. And which gas is most responsible for respiratory drive? Obviously the CO2. So these can be the potential questions. Then coming to the peripheral chemoreceptors, the peripheral chemoreceptors are the bodies, whereas the sinus term is used for the baroreceptors, the carotid body, and the aortic body. Same vagus and glossopharyngeal carries them. And this peripheral chemoreceptors are having tremendous amount of blood supply. This is very, very important. If a single tissue is asked which has maximum blood supply, it is the chemoreceptors, the peripheral chemoreceptors. Around 2 liters of blood is being supplied to just 100 grams of tissue. That's why peripheral receptor gets a tremendous amount of blood supply. And it uses only the dissolved form of oxygen. It is using only the dissolved form of oxygen. The hemoglobin bound form is not used by it. And the most important stimuli for this is the hypoxia, decrease in PO2. Whenever the question says most sensitive to, what changes? Again, PCO2. Both the central as well as the peripheral chemoreceptor, both are sensitive to. If the question says sensitive to, it is PCO2 is the answer. Whereas stimuli is hypoxia for the peripheral, central we have the H+ ions. Then activation of the glomus cells are the cells which are present in the peripheral chemoreceptor. How are they getting activated? Hypoxia, we said it is the stimuli, but how this hypoxia will induce the changes and send it to the brain? Whenever there is an hypoxia, what happens is they block the potassium channels. These potassium channels are called as hypoxia sensitive potassium channels. So more and more potassium will get accumulated inside the cell. What will happen? It will cause a depolarization. Here potassium channel is causing depolarization because inside positivity is being increased. So whenever inside positivity inside the cell is increased, it will cause depolarization. And because of this, the neurotransmitters are released, and ATP is the predominant neurotransmitter that is released by the glomus cells. Previously the answer was given for dopamine, because ATP was not studied in recent editions of Guyton. Previous editions was saying it is dopamine, but recent edition says that it is the ATP. ATP is more importantly secreted than the dopamine, then finally the acetylcholine. So these are the three important stimulus. So coming to the applied aspects, few applied aspects. First applied aspect is respiratory dysrhythmias. Just a minute. I'll just have some more. First applied aspect is respiratory dysrhythmias. Here, two most important ones are the Koncpt breathing and Biot's breathing. In Koncpt breathing, what happens is we can see this classical pattern, this crescendo decrescendo pattern. That is a constant increase in respiration followed by a decrease in respiration. So that pattern is called as the crescendo decrescendo pattern followed by apnea in between. Is called as the Koncpt breathing. Where does it happen? It happens in bilateral cortical disease, congestive heart failure. This is one of the most important thing, congestive heart failure, then sleep in high altitude, as well as premature infants. This type of breathing, crescendo decrescendo pattern, is called Koncpt breathing. Whereas coming to the next type of breathing, where there is near equal volume of breath separated by apnea. Here we can see that the volume of breath is near equal in each of the breaths. And this happens in meningitis. It was initially studied by this Boyard scientist in meningitis patients. That's why this is called as Boyard's breathing, because previously it was called meningitic breathing meningitic because it was found predominantly in meningitis patient, and the scientist was identified as Boyard. Then other than that, it can happen in medullary disorders also. Then coming to hypoxia. Hypoxia means it is the deficiency of oxygen at tissue level. So whenever there is a deficiency of oxygen at tissue level, it is called hypoxia. Hypoxemia is the term used whenever there is a deficiency of oxygen in the blood. There are 4 different forms of hypoxia. That is hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and histotoxic hypoxia. All these hypoxias are very, very important. So basically how we are going to discuss them is, first we will see the cause of that hypoxia, why that hypoxia is happening. Then few examples of each of the hypoxia, then levels of dissolved and hemoglobin bound oxygen. Why it is important is because in peripheral chemoreceptors we saw this dissolved oxygen is the one which is giving the supply. So whenever dissolved oxygen, that is the dissolved O2, decreases, then only they will stimulate the peripheral chemoreceptors. If the dissolved oxygen is normal, they are not going to stimulate the peripheral chemoreceptors. This is an important point. Action on the peripheral chemoreceptors is dependent only on the dissolved oxygen. Then cyanosis present or not. What is cyanosis? It is a bluish discoloration which happens due to the deoxygenated blood, and whenever this amount should go more than 5 milligram per deciliter, then only cyanosis can happen. Then finally, oxygen therapy, whether oxygen therapy is useful to that particular hypoxia or not. That is what we are going to discuss. So first coming to the hypoxic hypoxia. Here hypoxic hypoxia, as the term indicates, like in a high altitude, somebody is going into the mountain, what will happen? The atmospheric levels of oxygen itself is very less. So the availability of O2 itself is less. So what are the examples? High altitude, foreign body obstruction, ventilation, perfusion, imbalance, anything can happen. Here what will happen? Atmosphere oxygen itself is less. So both the dissolved as well as the hemoglobin bound, both the dissolved as well as the hemoglobin bound will be decreased. Whenever the dissolved is decreased, I told you peripheral chemoreceptors will be stimulated. And obviously in a high altitude, most of us would have experienced cyanosis because there is a very less amount of oxygen available, and the deoxyhemoglobin can go beyond 5 milligram per deciliter. So cyanosis again can happen in high altitude. Just remember one example, classical example, high altitude. Rest of the features you can identify. Obviously, whenever we go to Leh Ladakh and all, sometimes some people they will be given oxygen therapy. Obviously, oxygen therapy will be gratefully helpful because hypoxic hypoxia, oxygen is less, so give oxygen. So oxygen therapy is maximally useful in case of hypoxic hypoxia. Just remember this point. Then coming to anemic hypoxia. In anemia, what is the major problem? The major problem is there in the reduced hemoglobin. The hemoglobin bound oxygen decreases. There are 2 classical examples. One is anemia itself, another one is CO poisoning. CO poisoning, why does it look like anemic anemia? Because CO will go and bind with the hemoglobin. If the hemoglobin is less or bounded by CO, the functionality of hemoglobin is reduced. So whenever the functionality of hemoglobin is reduced, it is called as anemic hypoxia. Here the dissolved O2 is normal because either the hemoglobin is less or CO is going and binding with the hemoglobin. The hemoglobin bond is decreased. So what is the disadvantage in anemia as well as CO poisoning? The disadvantage is dissolved form is normal, so the peripheral chemoreceptors will not be stimulated. This is very, very important. The peripheral chemoreceptors will not be stimulated. And cyanosis will be very rare because we need 5 milligram per deciliter of deoxygenated blood. Anemia, already the oxygen levels are very less, so hemoglobin levels are very less, so cyanosis is quite rare. Oxygen therapy is not helpful because here the problem is with the hemoglobin. Not even if you give oxygen therapy, the hemoglobin is not able to carry it either because it is reduced in quantity or it is occupied by CO. Then coming to stagnant hypoxia. Stagnation, as all of us know, reduction in blood flow. So it can happen due to shock, hypotension, congestive heart failure. Here what happens? Both dissolved as well as hemoglobin oxygen will be normal because stagnation is happening in one place. Rest of the part of the body, both dissolved and hemoglobin will be completely normal. This peripheral chemoreceptor stimulation usually does not happen, but if there is a major stagnation, huge amount of blood is stagnated and more oxygen is extracted from the same blood, what will happen? More and more dissolved also will be reduced. Dissolved oxygen also will be reduced. So the peripheral chemoreceptors will be stimulated at a later stage whenever there is a severe form of stagnation. And cyanosis, obviously it will be present. Why? Because of stagnation, every 100 ml, 4.6 ml is of O2 is delivered, but this blood is not moving out. So more and more oxygen will be taken from the same blood. So what will happen? This will cause a severe form of deoxyhemoglobin state, which is leading on to the cyanosis. O2 therapy, obviously, it will not be useful because the stagnation has to be corrected. There is no problem in the oxygen availability. Then coming to histotoxic hypoxia. Histotoxic hypoxia, everything is normal here. Here the problem is with the tissue. Here there is a problem with the tissue. Tissue is not able to use oxygen. What are the classical examples? Histotoxic. The tissue has become toxic now. So one toxin is cyanide poisoning. Next thing is beriberi. Another one is beriberi is the example. Here both dissolved and hemoglobin bound, everything will be normal. So if the dissolved is normal, all of us think that there will not be stimulation of peripheral chemoreceptors. But here the catch is the cyanide can directly stimulate the peripheral chemoreceptors. They are the direct stimulation for peripheral chemoreceptors. And cyanosis will never happen because dissolved hemoglobin bound, every oxygen is normal. The problem is only with the uptake by the tissue. Tissue has become poisonous. O2 therapy is completely useless because hemoglobin bound, dissolved, everything is normal. Even if I give extra oxygen, it is not going to be of any benefit to the person. Now coming to the other applied aspects, the high altitude as well as the deep sea physiology. We'll just highlight the very important points. First one is high altitude is like a hypoxic hypoxia. Here what happens is the first change, if the question is asked, what is the first change that happens during acclimatization? It is hyperventilation. That is the classical question that is asked. It is due to the stimulation of chemoreceptors. What will happen? There will be a respiratory alkalosis. So we start hyperventilating and more carbon dioxide will be thrown out. This respiratory alkalosis will be corrected by a metabolic acidosis with the help of renal system. Then the diffusion capacity increases, the RBC count increases, new vessels develop, cell mitochondria, everything increases. But the classical question that is asked is hyperventilation is the first change. How RBC is increased? This is again important because there is severe hypoxia which will produce a factor called as hypoxia inducible factor HIF. This will increase the erythropoietin, and erythropoietin, all of us know, it is a direct stimulant for the RBC. And the angiogenesis happens with the help of VEGF, that is vascular endothelial growth factor. And there are mountain sickness which is called as acute mountain sickness, and the presentation can vary into 3 different forms. One is the acute mountain sickness, another one is HASE, another one is HAPE. Acute mountain sickness means there will be a headache, irritability, breathlessness, nausea, vomiting. Out of this, if the question is asked, which is the one symptom that is a must, it is headache. Acute mountain sickness. In acute mountain sickness, there will be, if there is an addition of cerebral edema, that's why it is called HASE, high altitude cerebral edema, and HAPE is high altitude pulmonary edema. If cerebral edema is there, then it is called HASE. So what happens here is due to the severe lack of oxygen, there will be excessive vasodilatation, which happens in case of the cerebral blood vessels, and capillary leakage will be there. And especially there is an edema in the corpus callosum, which is connecting the two hemispheres. And there could be a pulmonary edema. Why pulmonary edema will happen? Hypoxia will cause vasodilation in all the places except, the question can be there, hypoxia will cause vasoconstriction in the lungs. Why it is causing vasoconstriction in the lungs? Because if oxygen is not available, ideally the lung is doing a good thing, it will divert this blood supply to the other parts so that it can get oxygenated, because oxygenation is the function of the lung. That's why it is causing the vasoconstriction. Hypoxia everywhere else in the body will cause vasodilatation except in the lungs. That is called as hypoxic pulmonary vasoconstriction. But now everything is vasoconstricted. So what will happen? There will be a stress failure, because now the right heart has to pump at a high force, and they will cause a stress failure of the vessels, and there will be capillary leakage. So pulmonary edema can happen. So these are the features of acute mountain sickness. And chronic mountain sickness, if the person is staying there for a very long time, sometimes adaptation happens, but that will be sometimes the adaptation happens too much, that is not so good. The increase in RBC, increase in hematocrit, it is good, but they will increase the viscosity of the blood. As in when the viscosity of the blood is increased, what will happen? The tissue flow itself is reduced, which is not so good. And there will be development of pulmonary artery hypertension and leading on to the right heart failure. These things can happen in chronic mountain sickness. For the pulmonary hypertension, the drug of choice is the nifedipine. Nifedipine is given as a drug of choice. So what is the general management for altitude sickness? The first thing is we should ask them to descend to the lower altitude on oxygen therapy. It is a form of hypoxia. Hypoxia is the problem, so give them oxygen. Then acetazolamide. Most of the people who are going to Leh Ladakh, they take the tablet Diamox, that is acetazolamide, even 2-3 days before, because they help to increase the respiratory rate. And glucocorticoids. If there is an edema, to subside the edema, whether it is pulmonary or cerebral edema, the glucocorticoids can be used. Now coming to the deep sea physiology. Deep sea physiology is, first, it can be two things. One is whenever the person is going inside, there is high pressure outside that is compressing the gases inside the lung. And the same thing, whenever the person is ascending up faster, then there will be development of bubbles. So the first part, whenever he is going down, there is effect of increased gas pressure. Whenever he is ascending up faster, it will lead to decompression sickness. So these are the two important defects that can happen. So let's discuss the first one, hyperbarism. What happens whenever he keeps on going down? The partial pressure of all the gases increases, and they will cause nitrogen narcosis, oxygen toxicity, and CO2 toxicity. All the gases are causing the toxicity. This is called nitrogen narcosis because the person behaves as if he is under some narcotic influence, but he is ultimately dying, but he acts as if he is having some narcotic influence. So this nitrogen narcosis looks like an alcohol intoxication. Why it is happening is because this N2 can dissolve in the neurons, and they can cause this kind of altered behavior. This is also called as martini effect. As the drink martini cocktail, which is prepared, the person behaves as if he has taken one shot of martini for every 30 meters below the 250 feet wall. 250 feet. Usually this joviality happens in 120 feet, and 250 feet, this nitrogen narcosis starts to happen. And as in when he is descending more and more, for every 30 feet, it behaves like as if he has taken one additional shot of martini. That's why it is called Martini's effect. It is also called raptures of death. And there is an increased pressure of oxygen. All of us think that oxygen is good, but whenever there is too much of oxygen, there will be generation of too much of free radicals. So there will be membrane damage. Even the person can go in for coma and seizures. So these are the problems with oxygen toxicity. Too much of oxygen is also not good for anything. Then CO2 toxicity. All of us know that whenever there is a rise in CO2, we are discussing the chemical regulation also, it will always stimulate the respiratory system. But beyond a certain limit, like if the CO2 levels partial pressure goes beyond 80 mm of Hg, it will cause the respiratory depression. So this is very, very important. So this brings us to the end of the respiratory system. If the person is ascending up faster, then he will lead on to decompression sickness. So what happens, all the compressed gases, they will start into forming the bubbles. Last 2 years before, this Caisson's disease was asked as a question. So they will, this disease is also called as Benz, compressed air sickness, Caisson's disease, diverse palsy, dysbarism. All these terms are used for the decompression sickness. So any of it can be in the question. So why it is called bends? Because this bubbles that are formed, they can go and block anywhere. First thing, it can go to the joints and block them. It can go to the capillary vessels and block them. So it's called bends in case of the joints, chokes in case of the pulmonary vessels. Then this N2 bubbles can even obstruct the pulmonary artery completely, and there can be a pulmonary embolism also. What is the management? The management, best management is to use scuba. These are self-contained underwater breathing devices. Whenever scuba is used, this kind of dysbarism is not happening. Another thing is, if the person is ascending rapidly, then they will be put into the tank decompression. They will be put into a tank where the pressure will be gradually reduced, so that this nitrogen bubbles which is forming, they can be expired out, and there are not formation of any big nitrogen bubbles. So this is all about the respiratory system. We'll take a short break and we'll meet around at in 10 minutes. 9:05 we'll meet around. Okay. Hope you are hearing me.
Okay, sir.
Only major system that is remaining is the central nervous system. Rest everything is our short systems. We'll try to cover it. We'll try to wrap it around like 10:30 maximum. Okay. Thank you. Okay, am I audible? Can you hear me? Just drop a text. Can somebody say anything? Yes, that's okay. Okay, we'll start it. Okay. So now we are going to start with the central nervous system, and it will be discussed under sensory system, motor system, and higher function. Sensor system is mostly like CNS is most of the facts only. So most of the things we are trying to remember it. So first coming to the tactile receptors, sensory system will start from here and go to the CNS, whereas the motor system will start track from the cerebral cortex and come down below. And then we'll be discussing at the end some higher functions. So coming to the tactile receptors, there are four important receptors: Meissner's corpuscles, Merkel cells, Pacinian corpuscles, and Ruffini endings. And two of them are located superficially, as you can see here, the Meissner's and Merkel's. Both M are located superficially, and Pacinian and Ruffini are located deeply. In this, two corpuscles, both the corpuscles, that is the Meissner's as well as Pacinian, both of them are rapidly adapting receptors, whereas the other two are slowly adapting receptors. And the most important thing is, what is the best stimuli? For Meissner's, it is the movement which is the best stimuli that can be detected. And touch, points, edges, and texture, all of them are done with Merkel. If they are asking an MCQ with respect to these receptors, they will be most likely asking a Merkel disc, because it is the one which is involved in touch, points, edges, texture, which is used in braille reading. Braille reading is the one which is used by the blind people. So obviously they should be able to touch it and feel it, and surrounding edges they should know, because their platform is raised, so they can understand. Whereas vibration is usually sent by the rapidly adapting receptors in the deeper section, that is the Pacinian, whereas prolonged touch and pressure will be sensed by the Ruffini. Just remember this important point, that is the braille reading. Then coming to the nociceptors or the pain receptors. Pain is sensed by the free nerve endings, and pain is generally classified into the fast pain. For example, whenever we touch something that is injurious, we suddenly withdraw it. That is the fast pain, that is due to the fast pain. Then after that, on a longer duration also, there will be some kind of pain. That will be the slow pain. So fast pain is called as pathological, acute, first, or a good pain, because we are able to withdraw it from the stimulus. Slow pain is called pathological, chronic, second pain, or a bad pain. Here the fibers are important. Fast pain is carried by the A delta fibers. And I told you A fibers are myelinated, so they are able to carry it faster. Whereas C fibers are non-myelinated, that's why they are carrying it slower. And what is a neurotransmitter that is released by this nerve ending? It is the glutamate for fast pain and substance P for the slow pain. And fast pain, usually they are very sharp. You touch it, you suddenly feel the pain and remove it. But slow pain, they will be dull and diffuse, and they are the ones which will not allow you to sleep at night. So they are dull and diffuse. So they are carried with the help of spinothalamic tract. The spinothalamic tract is the one which carries the pain fibers. And in pain fibers, there are two different tracts. One is the neospinothalamic tract, another one is paleospinothalamic tract. Neo is the one which is carrying the fast pain, and they will reach only the somatosensory cortex via the thalamus. Whereas the slow pain, they will reach thalamus. At the same time, they will also reach the reticular activating system, RAS system, then periaqueductal gray matter, then tectum of mesencephalon. Since that is why this reticular activating system is keeping us awake at night, because the slow pain is dull and diffuse, and it constantly does not allow us to sleep also, because of this innervation to the reticular activating system. So once it reaches the central nervous system, there processing will happen. One, for pain, the most important center is the thalamus. The perception of pain is done at the level of thalamus. All of us think that it is done at the level of somatosensory cortex, but thalamus can do the perception of pain. Whereas discrimination of the pain or the assessment of quality of the pain will be done with the help of somatosensory cortex. Then the medial brain system, which is controlling the motivational aspect, they will go to the insular cortex. But this is the most important point, that perception of pain is by thalamus and discrimination is by the somatosensory cortex. Then pain modulation. Pain modulation can happen at the spinal level also or supraspinal level also. Spinal level, this gate control mechanism is very, very important. What is gate control mechanism? So whenever we are injured, what we tend to do, we used to rub our hand, shake our hand, or rub the surrounding area. What are we trying to do? We are trying to block the gate of the pain fibers. Pain fibers is carried by the A delta C fibers. But whenever we rub and shake the hand, what happens is the A alpha and beta fibers are activated, and these are cutaneous mechanosensitive afferents. So what they generally do is they will glow and block the gate of the pain fibers. So that is why it is called gate control mechanism. Touching or rubbing is the one which is stimulating this A alpha and beta fibers. These are large fibers also, so they override the pain fibers, but this is not a complete treatment. It overrides them for a certain period of time. And this forms the basis of acupuncture therapy as well as the TENS therapy. What is TENS? This is transcutaneous electrical nerve stimulation. So both are based on the gate control mechanism. So that we have to remember. Second thing is opioids. Opioids like enkephalins and dynorphins, endorphins, what they do, they will stop the pain both presynaptically as well as the postsynaptically. So in the spinothalamic tract, whenever opioid is given, they are going to act in both the regions, both the presynaptic as well as the postsynaptic regions. Then role of the central higher levels. In the higher levels, the important nuclei are the periaqueductal gray matter and locus coeruleus. These are the two important ones. And they will give their impulses lower down to the nucleus raphe magnus, which will produce a serotonin. So the hormones like serotonin, norepinephrine, all this, they will suppress the pain. So this rostral ventrolateral medulla via the locus coeruleus will produce the norepinephrine. The end products of this, the serotonin, norepinephrine, are ultimately reducing the pain impulses. And there is something called as stress-induced analgesia. This is very, very important. Why? Because whenever there is a strong emotion, a soldier is fighting in a battlefield, like they show it in the movie Pagubali also, like they are fighting in the battlefield, suddenly everybody gets enthusiasm and to fight back again. So that kind of strong emotions will block the pain. How does it happen? It happens with the help of two places. One is the amygdala region. Amygdala is the one which is involved in emotions. Wherever you study emotions, always amygdala will be involved. And they are the ones which release the norepinephrine. And there is production of some endogenous cannabinoids like 2-arachidonyl glycerol and anandamide. Both this will help to reduce the suppress the pain. In a battlefield, what happens is sometimes whenever this is another concept called phantom limb pain. In a battlefield, sometimes whenever the soldier's leg is amputated, sometimes they feel that as if their leg is still present. That is called phantom limb pain. Why does it happen? Because of the remapping and reorganization that happens in the thalamus. That happens in the thalamus as well as in the somatosensory cortex. So both places it happens, this reorganization and remapping. So that's why the person feels as if its limb is still present. In World War II, most of the people had these symptoms. Now let's talk about the proprioceptors and spinal reflexes. In this, you just have to remember which is causing which type of reflexes. For example, the muscle spindle. The muscle spindle is the one which is responsible for the stretch reflex as well as withdrawal reflex. But sometimes the question might be asked, which is responsible for the inverse stretch reflex. Inverse stretch reflex is done with the help of Golgi tendon organ. So what is stretch reflex? So whenever we tap with a knee hammer, there is stretch of the tendon and there will be contraction of the muscle. This is what we generally do it in reflexes. This is done with the help of a muscle spindle. This muscle spindle is also called as intrafusal fibers. For example, whenever there is a muscle like this, the outside fibers, which are the contractile unit, like a biceps muscle, complete muscle, are called as the extrafusal fibers or the muscle fibers. Whereas inside them, there are sensors. They are called as the intrafusal fibers or the muscle spindle. And in the tendinous ends of the muscle, there is something called as the Golgi tendon organ. So already we saw that the intrafusal fibers or the muscle spindle is responsible for the stretch reflex as well as the withdrawal reflex. And Golgi tendon is responsible for reverse stretch reflex. There is one more innovation which is important, that is called the gamma motor neuron. Why this gamma motor neuron is important? Because sometimes whenever the muscle, we try to tap it and there is no reflex, what we ask the patient? We ask the patient to clench their teeth. At the same time, otherwise for the lower limb, we'll ask them to clasp their finger and pull it apart. What are we trying to do here? Here we are trying to increase the sensitivity of the reflex. How it is happening is this A delta C, A gamma fibers, which are the efferents, which is present in the peripheral part of the muscle, peripheral part of the muscle fiber. It is present in the peripheral part of the muscle spindle actually. So if this is contracting, what they will do, they will stretch the muscle spindle. If the muscle spindle is already stretched, when I tap it, it gives an additional stretch. So that is the reason why this clenching of teeth as well as pulling the hands apart is done when performing a motor reflex. So this gamma motor neurons are the ones which is responsible for this genera 6 manure, which we do it in the elicitation of the reflexes. They basically increase the sensitivity of the stretch reflex. Then Golgi tendon organ, already we told you that it is inverse stretch reflex. What is inverse stretch reflex? Stretch reflex is when I tap it, it has to contract. But if you tap it very forcefully, what will happen? The muscle will relax. Why it should happen? By tapping very forcefully, it can cause the avulsion from the tendon. To prevent that, what will happen is there will be relaxation of the muscles. Why does this normally does not happen? Because Golgi tendon organ sensitivity is low. Whenever you give a very strong stimulus, then only it will get activated and relax the muscle. And this helps to prevent the avulsion of the muscle tendon from the bone. So that is the importance of it. Now we are done with the receptors. Now we are going to follow them through the tracks. In tracks, the ascending tracks, two important tracks are there. One is the dorsal column pathway. Another one is ventrolateral spinothalamic tract. This you will study it in anatomy also. So the dorsal column pathway is going to carry fine touch, vibration, proprioception, and pressure. They will take it to the somatosensory cortex. With the help of somatosensory cortex, they will be able to do 2-point discrimination, stereognosis, ability to identify objects with closed eyes, graphesthesia. If you write something, the person can identify other person. Then tactile localization. So all this sensation are carried by the dorsal column. And in this pathway, I want you guys to remember where does the degradation happens. Degradation happens in the medulla. This is not the question, but this will help us to attend the Brown-Sequard syndrome. So here the decussation is happening at the medulla. So this is just the pathway, same pathway. Here the decussation happens at the medulla. Crossing over happens to the medulla to the other side. So from the periphery, it goes to the somatosensory area 312. And the primary sensation carried, we have already discussed. Now coming to the ventrolateral pathway, already we saw that pain is carried through the spinothalamic tract. That is the ventrolateral spinothalamic tract. Pain, temperature. These are the two important events that is carried by the ventrolateral spinothalamic tract. And crude touch, sexual sensation, itch and tickle. They are also carried by the ventrolateral spinothalamic tract. And the decussation happens at the spinal cord level itself. It is very, very, very important. I'll tell you what is the importance in a while. Here, what is happening? As you can see here, here it comes and the decussation happens here. The decussation happens at the spinal cord level itself. The decussation is happening here itself at the spinal cord level. This is important when we study the Brown-Sequard syndrome. So decussation for the dorsal column happens at medulla, and for the ventrolateral spinothalamic tract, it happens at the spinal cord. You just remember these two things. We'll come back to them. So all of the sensation, they pass through the thalamus to reach the somatosensory cortex. All of them reach. So there should be some exceptions. What is the exception? Exception is olfaction. Even though the recent editions of books says that olfaction also pass through the thalamus, but still for MCQs, all of them will pass through the thalamus except olfaction. And all of the thalamic nuclei are excitatory except thalamic reticular nuclei. There is a specific nuclei called thalamic reticular nuclei which is present in the thalamus. It is an intrathalamic connection and it is an inhibitory in stimulus. And thalamus, already we have shown what does it do? It can sense the or perceive the pain. The perception of pain as well as temperature is done at the thalamus. Why it is done at the thalamus, not at the somatosensory cortex? Because even in smaller animals, this thalamus is the one which is sensing the pain. Their somatosensory cortex is not well developed, but still their animal will understand it is having a severe pain. But it will not be able to discriminate the type of pain because for discrimination we need the higher somatosensory cortex. Then comes the sense, even tactile sensations, crude tactile sensation can be sensed by the thalamus. So these are the major function of thalamus. but olfaction is not carried by the through the thalamus. Then coming to the from the thalamus, it will reach the somatosensory cortex. The somatosensory cortex is located just behind the central circles. In anatomy, you will study there is this big central sulcus. Just behind is the somatosensory cortex. In front is the motor cortex. The somatosensory cortex is further divided into somatosensory area 1, which is the primary area, that is Brodmann area 312, 312, and somatosensory area 2. And not only this, there are some association areas, which is very, very important for associating and analyzing the sensation. They are area number 5 and 7. And the body is usually represented in the brain whenever a sensory homunculus or a motor homunculus is represented. A human diagram will be there where it will be represented according to the proportion of its function. According to the proportionate of the function, the area will be occupied. For a sensory stimulus, lips is the one which is having the maximum representation. So this is important. Now, what are the functions of a somatosensory cortex 1? I told you in dorsal column itself, the important point is that there are something called as cortical sensation, where you need an intact cortical sensation for 2-point discrimination, tactile localization, judging the weight and texture, and stereognosis, graphesthesia. For all this, you need a cortex. So if they are affected, it is called astereognosis, agraphesthesia. In this person, what will happen is he will be able to feel it. Suppose you place something in his hand, he will be able to feel it, but he will not be able to understand what it is. So that's why it is called useless hand syndrome. Hand is there, but it is useless because it is not able to make meaning out of it. Or tactile apraxia. So that is the one which will happen if the somatosensory area 1 is damaged. Somatosensory area 2, it is for cognition. It is for understanding. That is the only function that has been depicted. Then somatosensory association area. This is the one which helps to decipher the deeper meanings of the stimulus. And it is the ability to identify complex objects, because association should happen to identify the complex things. So that's why somatosensory association area is very, very important. Whenever a somatosensory association area is damaged, even though the vision of the person is completely normal, or even though the person is able to understand the other side, whatever is placed in that particular side, he will completely neglect it. Whenever there is a damage to the somatosensory area, the person will have a contralateral hemi-neglect syndrome, because the fibers have already closed in the medulla. So they will have a contralateral hemi-neglect syndrome. So if he is asked to draw a diagram like this, he will be drawing half of it only. Sometimes it is said that they will hit only half of the plate because they are completely neglecting the other half of the food in the plate also. It can go to that level of severe extreme levels of condition. Okay. So what are some of the laws in sensory physiology? This can be an simple MCQs like, what is bell mesenteria? The dorsal root, whenever you draw a spinal cord, the dorsal side is always carrying the sensory, whereas the ventral root, it always carries the motor efferents. And there is something called as label line principle. What is label line principle? For example, a specific tract. For example, pain, it is carried through a specific tract like we studied, A delta C fibers to the central nervous system. So it means that this sensation is labeled by this line of fibers that is carrying the impulse and specific nerve energy. For example, wherever I stimulate in this tract, it will convey the same impulse to the brain. For example, if it is a pain pathway, wherever you stimulate it, it is going to convey the same message to the brain. And law of projection. Law of projection we have already discussed in phantom limb pain. We have already discussed in phantom limb pain. What happens here is, even though the limb is not there, but that brain area is adapted to project it to that particular area. For example, whenever there is a stimulation in the stump is the closure of the amputation site. Whenever there is a closure of the amputation site is there, it is stimulated, the nerves are being stimulated. What will happen is, the person will sense as if his limb is lying there, because the cortex is projecting it to the area where it is represented. So the cortex always projects onto the receptor from which the pathway starts. So it feels like a phantom limb. So these are the few laws in sensory physiology. So this is all about our sensory physiology. Now coming to the motor. Motor will start from above and come down. So coming to the motor cortex, it is located in the frontal lobe in front of the central sulcus, which I have already told you. Then it is primary motor area, premotor area, and supplementary motor area. Primary motor area located in the precentral gyrus. In front of the primary motor area is the premotor area. This premotor area, the motor action will be done by the primary motor area. But the formation of image, for example, if I have to pick up something, first I will form a motor image in my brain to pick it up. That motor image formation will be done by the premotor area. Whereas supplementary motor area, they are usually like climbing. For example, when we were animals, the climbing is done with bilateral actions. So that was done with the help of a bilateral contraction of muscles with the help of a supplementary motor area. But the main area is the primary motor area. So the primary motor area comes under the Brodmann area 4. It comes under the Brodmann area 4. And here also the motor homunculus is there. In sensory homunculus, which is the maximum part represented, sensory, it is the lips. Whereas motor, we talk a lot and do the work in the hands only. Most of it is done, most of the motor activity is done with the hands. So maximum representation is there for the speech and hand movements. Speech and hand movements. Now coming to the descending tracts. In descending tract, we have to know just one important tract, that is the corticospinal tract. The corticospinal tract, what happens with the corticospinal tract is, previously descending tracts were classified like pyramidal tracts and extrapyramidal tracts. The corticospinal tract was called as the pyramidal tract, rest all was called as the extrapyramidal tracts. But right now the newer classification is medial pathways and lateral pathways. Medial pathways are the one which controls the axial body position and everything. Laterals are the one which is converting the distal limbs. So now the classification is changed. But for our discussion, we have to know that corticospinal tract. So what happens in corticospinal tract here is, the third tract here is the corticospinal tract. It starts from the motor cortex and comes to the internal capsule, and it crosses. The decussation happens at the level of medulla. I keep on telling about the decussation point that we should remember because of the Brown-Sequard syndrome. What happens in Brown-Sequard syndrome is there is hemisection of spinal cord. There is hemisection of spinal cord. Here the injury is not happening at the higher level. Here there is an injury at the spinal cord level. So we have to know what happens to this particular person. For example, let's take the example of a right side lesion. Let's consider this is right side, this is left side. In dorsal column, where was the crossing? I told you in dorsal column, the crossing was in the medulla. Again, in the corticospinal tract, the crossing over is in the medulla. So let's try to understand here. So right side is damaged. Let's track it back. Which side is affected? Right side. So in dorsal column pathway, it is ipsilateral. Ipsilateral side is affected. Whereas in spinothalamic tract, you cut on the right side. What is happening? Just track it back. The decussation has already happened in the spinal cord. So obviously it is affecting the left side. So spinothalamic tract will be affected on the contralateral side. Corticospinal tract, it has already crossed in the medulla. So I cut it on the right side. Again, the injury is on the right side itself. Don't think about the origin of the fibers. Here we just have to focus where the injury is, which side is affected. Right side is injured, right side is affected. So again, corticospinal is ipsilateral. So which was the only contralateral? The only contralateral was spinothalamic tract. Just remember that contralateral spinothalamic tract pain and temperature is lost. Rest everything is lost on the ipsilateral side. For example, the Brown-Sequard syndrome, ipsilateral loss of dorsal column, fine touch, pressure, vibration, proprioception. Only the contralateral I will ask you to remember because only one is contralateral, that is the spinothalamic tract, which is affected, the pain and temperature is affected. Then ipsilateral loss of corticospinal, that will lead on to the paralysis. Then comes one important question, whether it is a decorticate rigidity and decerebrate rigidity. They will show the picture also sometimes and ask you what type of rigidity. We have to understand a lot of tracks, but for the MCQ level, I will give you a very easy mnemonic to remember them. In decorticate, calculate the number of E's. There are 2 E's. In both decorticate and decerebrate, both of them, the lower limb will go for extension. So here 2 lower limbs are going for extension because only 2 E's are there in the decorticate word. Okay. Then the upper limb will go in for flexion. So 2 upper limb will go in for flexion. In decerebrate, how many E's are there? 1, 2, 3, 4 E's are there. So in decerebrate rigidity, all four limbs go for limb goes for extension. All four limbs go for extension. So just remember this mnemonic. Whenever you see 4 E's in the question, then go in for all four limbs go for extension. Whereas in decorticate rigidity, what happens in is the lower limb goes in for extension. In decorticates, only the cortex is cut off. Whereas in decerebrate, the cut is in midbrain, between superior and inferior colliculus. But no need to worry about any of this. They will just have the features. In decorticate rigidity, what happens is the rubrospinal tract is preserved, and rubrospinal tract will cause the flexion of upper limb muscles. So that is the reason in decorticate rigidity there is an upper limb flexion, whereas in decerebrate rigidity, even the rubrospinal tract is cut. If that is also cut, already the lower limb will go for extension and the upper limb also will go for extension, because rubrospinal tract is causing the flexion of the upper limb, which happens in a decorticate rigidity. Now coming to the upper motor neuron and lower motor neuron lesion. Let's try to understand what is upper motor neuron. So whenever any CNS neuron originates and it comes down, it innervates in the spinal cord. From the spinal cord, the exiting neuron will be there. So the above one is upper motor neuron and the lower one is lower motor neuron. Upper motor neuron, think that as if he is a class leader or a teacher. Let's take he is a teacher. So whenever upper motor is there, what it will do is it will keep the lower motor under control. If the upper motor is gone, the lower motor will overact and do all its nonsense behaviors. Like when a teacher is not there, the student is going to jump around. And in a similar manner, whenever upper motor neurons are affected, what will happen? It is lower down, many neurons are being supplied by that. So all of them will go in for an affected. So upper motor neuron lesion, muscle group affected are multiple, whereas in case of a single. What happens to the tone? Whenever upper motor is done, it was keeping the control. So now what will happen? Now nobody is there to control the lower motor. It will go for a flexion or a hypertonia. But what happens in lower motor is it is the one which is supplying the end muscle. If the end muscle supply is cut, then obviously it will go for hypotonia. Then what type of paralysis will happen? It is severely spastic in case of upper motor because of the hypertonia. It is spastic paralysis. Whereas for the lower motor neuron lesion, it is a flaccid paralysis. So these are the major features. And in upper motor, it is flexed, it is hypertonia is there. But so usually what is happening? Muscle activity is going on. So there is very less chances for an atrophy. Usually the atrophy does not happen. That's why I crossed it. But still, if it is there for a very long duration, then disuse atrophy will happen. But if the nerve supply to the muscle itself is gone, there is a lower motor neuron lesion, what will happen? There will be atrophy which is always present. And the fibrillations and fasciculations are absent in case of an upper motor neuron, whereas it is present in a lower motor neuron. What is this fibrillation and fasciculation? So whenever a lower motor is cut, what will happen? The muscle will start to release some potentials which is causing slight fibrillations. And whenever this is getting re-innervated, by the time the muscle would have developed lots and lots of receptors, because it was not getting any influences, it will develop lots and lots of receptors. So that is called as denervation hypersensitivity. So this denervation hypersensitivity will cause this fasciculations. So fibrillation and fasciculations are always present in case of a lower motor neuron lesion. Then coming to the reflexes, both the reflexes will be definitely absent because the lower motor neuron itself is cut. So both the reflexes will be absent in case of a lower motor neuron reflexes. Whereas the deep reflexes are usually exaggerated. Why? Because upper motor neuron is not able to control now. There is a lesion. So what will happen? Even when you tap it, there will be a severe reflex or an exaggerated reflex. And in upper motor, the classical sign is a positive Babinski sign. There will be extension of the great toe and fanning of the other toes. So Babinski sign is positive in case of an upper motor neuron lesion. Upper motor neuron, just remember, he is the guy who is controlling the lower motor. So if he is gone, hypertonia will be there, spastic paralysis will be there, all the reflexes will be exaggerated. and Babinski's will be positive. So this is how you can remember the upper motor and lower motor very easily. Then coming to the basal ganglia has around 5 nucleus. So caudate nucleus, then putamen, globus pallidus, subthalamic nucleus, and substantia nigra. Out of this, the substantia nigra is very important because of the Parkinson's disease. So what happens here is this is called nigra because of the melanin pigmentation, and it has substantia nigra pars reticularis and pars compacta. This pars compacta is the one which will produce the dopamine. And if this substantia nigra pars compacta is affected, the person will have a Parkinson's disease. So let's try to understand the 4 different diseases that can happen due to these various kinds of neurons. So first thing is Parkinson's disease, we know it is the substantia nigra. Then next thing is lenticular nucleus. What is lenticular nucleus? This putamen and globus pallidus, they both look together like a lens in structure, lens-like structure. So it's called lenticular nucleus. So lenticular nucleus, hepatolenticular degeneration, you will read it. It is the Wilson's disease. Then two are easy to remember. Lenticular nucleus is Wilson's disease and substantia nigra is Parkinson's disease. Next is caudate nucleus. Caudate nucleus is Huntington's chorea. So caudate nucleus is affected. That is the major nucleus. If it is affected, it will lead on to Huntington's chorea. And subthalamic, you remember hemibalismus. Why it is hemibalismus? Usually one half of the body is affected, so it is hemibalismus. All these 4 are important. So substantia nigra is for Parkinson and lenticular is for Wilson. Remaining caudate, it is chorea, Huntington's chorea, C for C, you can remember. Then subthalamic nucleus is hemibalismus. So coming to Parkinson's disease, all of us know that it is a neurodegenerative disorder and dopamine is a neurotransmitter which is involved. The connection between substantia nigra pars compacta and putamen is affected. So putamen, the fibers which is going to the putamen is usually affected. And inclusion bodies in the neurons are called as the Levy bodies. Previously, it was called as paralysis agitans because of some paralysis that is happening as well as some tremors that is happening. So what is the classical triad? Classical triad is bradykinesia, resting tremor, and rigidity. So bradykinesia, resting tremor, and rigidity. The rigidity can be left pipe where there is a constant force affected, or a cogwheel type of rigidity. Both can be there, left pipe as well as cogwheel type of rigidity. And the gait, classical gait is called as Parkinson's gait or a Festinant gait, where there will be a stooped, short shuffling gait. And faces is the Parkinson faces. These features, most of you might be knowing it beforehand only. So remember the classical triad: bradykinesia, resting tremor, and rigidity. Then coming to the cerebellum, physiologically it is classified into vermis, intermediate zone, and lateral zone. Vermis is the one which is involved in the vestibular apparatus. Then intermediate zone is responsible for the control of the muscle. Lateral zone is responsible for the planning of the movements. So what is the main function of cerebellum? Main function of the cerebellum is to anticipate and correct the mistakes. So whenever cerebral cortex prepares any action, it will send to the muscles and it will send to the cerebellum. So it's like it is appointing cerebellum to look over it. So whenever there is a minor error, the muscle will send feedback to the cerebellum. That is sent with the help of ventral spinocerebellar tract. It carries one copy from the periphery to the cerebellum. That is called efference copy. Whatever action is going, suppose if I want to pick something and I am not able to reach it properly, there will be a slight, this copy will be sent to the brain and the cerebellum can correct it to reach the object. So this constant efference copy is always being sent to the cerebellum. So this efference copy is done with the help of a ventral spinocerebellar tract. That is important. Then cerebellar dysfunctions, it causes pass pointing, dysmetria, dysdiadochokinesia, dysarthria, drunken gait. The gait here is drunken gait. Cerebellar gait is drunken gait. And intentional tremors. In Parkinson, it was resting tremor. In cerebellum, it is intentional tremor. When an action is done, then only the cerebellum function starts to happen. So obviously, the intention, whenever they are starting to work, then only they will have an intentional tremor. Then they will have a cerebellar nystagmus. So these are the classical features. Now coming to the limbic system. The limbic system, one thing we have to remember here is it is the one which is the connection which is involved in behavior and emotion. Behavior and emotion. And the most important thing is, if they ask you, what is this modified? What is the modification done here? What is the new thing that is included here? It is the amygdala. The amygdala part is the one which is added in the Papa circuit to make it modified Papa circuit. And amygdala, I told you beforehand also, it is very, very responsible for emotions. And this amygdala is connected to the amygdala along with the hippocampus. They will give impulses to the hypothalamus. And this hypothalamus is connected to the prefrontal cortex and back again to the hippocampus. Here we have to remember a few important things or the functions. So amygdala, I told you, it is for emotional memory. Hippocampus is for short-term memory. And entorhinal cortex, rhinus means nose. So this entorhinal cortex is for olfactory memories. So these three important things we have to remember. These three important things. Rest everything will not be asked. Entorhinal cortex for olfactory memory. Hippocampus is for short-term memory. Amygdala is for emotional memory. So coming to the hypothalamus, some of it, some of the functions we'll be reading it in the endocrine also. For example, supraoptic is secreting the ADH, paraventricular is secreting the oxytocin. This we will read it in the endocrine also. But other than that, we should remember a few nucleus. For example, anterior part of the hypothalamus is involved in anti-rise. So whenever the temperature is rising, it will help to control that by sweating. It will cause sweating. Anti-rise region. This anterior we have to remember. And which is the master clock for the body? It is the suprachiasmatic nucleus. Suprachiasmatic nucleus is the one which is regulating the circadian rhythm. And one more thing, whenever the thirst or hunger is there, what we tend to do, we take something from the lateral side and eat it. Whenever you eat it, the satiety feeling happens in the medial side. So for the lateral nucleus, remember thirst and hunger. So whenever thirst and hunger, we take it from the lateral side. Whenever food goes medially to the stomach, there is satiety. So the appetite center or the thirst and hunger is the lateral one, whereas medial, ventromedial is the one which is for satiety. That is important. Then arcuate nucleus will produce the dopamine. Lateral I have told you already, thirst and hunger. Then posterior, anterior I told you it is for anti-rise. Whenever temperature is rising, it will cause sweating and help it. Whenever posterior, it is response to cold. Whenever cold is there, it will cause vasoconstriction and there will be anti-fall center. So posterior is anti-fall, anterior is anti-rise. Just remember these two. And ventromedial is for satiety and lateral is for the thirst and hunger. And most of us know that circadian rhythm is done with the help of suprachiasmatic nucleus. So these are the few important nuclei. Yeah.
So the anterior is for?
Anterior is for anti-rise. Whenever body temperature is rising, what it will do is it will cause sweating and help to reduce the temperature. Anti-rise.
Okay, sir. Okay, sir.
Okay. Posterior is for cold. Whenever too much of cold is there, it will help to preserve the heat response to cold. So this is all about our motor system. Motor system, you started with the motor cortex and discussed about some of the cerebellum and basal ganglia. Cerebellum and basal ganglia, they are also having the motor control. That's why even in diseases of basal ganglia, we have some motor disorders. All the nucleus will have a motor disorder. Then coming to the EEG and sleep. In what is EEG? It is nothing but the electroencephalogram. So basically, whenever it is recorded in the scalp, it is called electroencephalogram. Sometimes it will be recorded inside the cortex. So that is called electrocorticogram. It is the pial surface. If it is recorded from the pia mater, it is called electrocorticogram. It is a record of dendritic potential. Here we are not recording the action potential. Here we are recording the dendritic potential. That is potential from all the dendrites. All the dendrite, whatever combined potential they are giving, that we are recording out here. And the scientist's name, you have to remember, it was asked in Ames question also even, Hans Berger. The scientist's name is Hans Berger. So what is the waves of EEG? EEG, just remember the waves as G, BAT, D. G, BAT, D. So this G is the one for gamma, beta, alpha, theta, and delta. These are the waves produced. We have written in a way that the frequency is reducing. So frequency keeps on reducing, starting from gamma to delta, and the amplitude keeps on increasing. For example, if the frequency is less, what will happen is the number of waves will be less, but they will be tall. So that's why the frequency which have very less frequency, they will have a high amplitude. Like this is an example of deep sleep. So coming to this gamma waves, whenever you are trying to listen to the class and you are putting your full attention to it, that will develop a gamma wave. So now we have to start reducing the waves, so frequency. So if you are awake but not paying much of attention, then that is called wakefulness, which is giving the beta wave. Now if the class is very monotonous and your exams are little far, then what we'll do, we tend to rest with the closed eyes. With closed eyes, you might be listening, but you're not taking much of the input. Whenever resting with closed eyes is there, he's not sleeping yet. He has not slept yet. Resting with closed eyes will give the alpha wave. The person is awake with closed eyes. That gives the alpha wave. Then theta wave, usually it is found in the hippocampus. It should happen whenever the transition is happening to the sleep. Other times, if it happens, it means that the brain is in a pathological state. Then finally, the deep sleep is with the help of delta waves. So again, the sleep is generally classified into non-rapid eye movement sleep and rapid eye movement sleep. The name itself says in one we have the rapid eye movements. Non-rapid eye movement sleep, this is called as a proper sleep. That is called as the orthodoxical sleep or a slow wave sleep or a quiet sleep. Why? Because in rapid eye movement, we'll see the EEG waves looks like as if the person is awake. Here, the person is actually sleeping, and that is why it's called orthodoxical sleep. So previously, they were classified into stage 1, 2, 3, 4, but right now they are combined 3 and 4 to N3. N is the one which is indicated for non-REM. Non-REM 1, non-REM 2, non-REM 3. Non-REM 1, the person is just transiting from awake state to the sleep state. Awake state, whenever you are closing eyes, the wave will be alpha. Whenever it is going into theta, the transition will happen. If the awake person with closed eyes, open eye, from eyes closed, for example, the alpha wave is coming, then eye opened. If he suddenly asks to open the eyes, this alpha wave will be blocked and it will come to beta wave. So this is called as alpha block. This is just one additional statement. This is called as alpha block. For example, with eyes closed, the alpha waves will be there. Whenever suddenly we open the eye, some external influences or the light is coming up. So the alpha waves will be blocked. Usually the alpha block will be there, it will convert to beta wave. Now coming to the N2 stage. N2 stage, two important things will be there. One is the sleep spindles. If the question says the person is having sleep spindle and K complex, then obviously it is an N2 stage of sleep. What is sleep spindle? Sleep spindles have this particular frequency, particular duration, and particular voltage. These are called as sigma waves. Whenever in an EEG, they are called as sigma waves. And what is K complex? This K complex is little easier to identify in ECG. These are biphasic high voltage, and ECG will be recorded like EEG will be recorded like this, and suddenly a biphasic high voltage will come like this. So this is the K complex, and this K complex indicates that the person is in N2 stage of sleep. And finally, the deep sleep, delta wave will be there. Coming to the REM sleep, it is also called as paradoxical because the EEG recording shows as if the person is active. Then superficial sleep. These are rapid low voltage resembling an awake state. For the REM sleep, we have to remember one thing. The brain is highly active here. The brain activity seems like as if the person is awake. Here, there is an increase in ACH activity. And these spikes, they can ask this as a question, are called as pontogeniculo-occipital spikes. Because from the pons, geniculate body, as well as the occipital region, there are waves that is produced by this increased activity of ACH. The person is sleeping, but the waves look like as if the person is actively thinking about something. Now coming to learning and memory. What is learning? Learning is just the acquisition of knowledge. I tell you something, you acquire it, that is learning. But in the exam, you are able to reproduce it, store it, and retrieve it. Then that is called as memory. Memory is the process of encoding, storing, and retrieving the knowledge on a later date. So coming to the classifications of memory. So memory is classified basically on the duration, that is short term, intermediate, and long term. Short term to long term happens due to consolidation with the help of hippocampus. Then short term, there is another form of short term memory which is called as working memory. All of you would have received an OTP and you will remember it for a very short span of time. You will be keeping on repeating till you enter into the mobile. That kind of memory is called working memory, and it happens with a prefrontal cortex. It happens with the prefrontal cortex. Then coming to the forms of memory, what are the different, this is one classification based on the timing, like short term, intermediate and long term. Coming to the different forms of memory, they are called as explicit or declarative. What does you mean by declarative? Declarative means that we consciously think and give the answer. That is called declarative. Implicit or non-declarative, like these are reflex kind of actions or comes under reflex kind of memory comes under the non-declarative. So for this, they need a conscious awareness in case of explicit memory. And they are classified into episodic and semantic. It is pretty simple. What is episodic? If you are able to remember the entire day, like your friend's wedding or something, or a birthday of yours, you are able to remember the entire episode. For that, you have to actively think like what happened first, what happened next. That kind of memory is called as episodic memory. But then semantic. Semantic is for the facts. If you are able to remember facts with a sequence, for example, JVP, if you are studying, you are remembering A wave is there, V wave is there, C wave is there. That kind of factual memory is called semantic memory. For both of this, you need the active consciousness. If you don't need active consciousness, it becomes implicit memory. Implicit memory is further classified into, it is pretty simple, procedural. If you learn a procedure, for example, you are starting to drive a car. Initially, it will be explicit, but once you learn it, you will just drive it without your own influence. So car driving is the best example for it. And it is done with the help of striatum, cerebellum, and motor cortex for the motor coordination. Then priming. Priming means you will do it reflexly, but there is some preliminary information for it. For example, if I write blue, red, and GR dash dash dash, what's your answer? Most of you will answer one thing only. So it will be green. But the same example, if I do same GR dash dash dash, now most of you will answer it as grape. What has happened here? I have given a priming information to you. You will answer it reflexively because of the priming that has been done. So this is the color priming I have done. This is the fruits that I have given as a priming. So this kind of memory is called priming memory. And associative learning. If you are able to associate something and learn, then it becomes a more associative learning. The classical example is Pavlov's experiment. And non-associative learning. This is not an association. You just learn it. That is called habituation and sensitization. What is habituation? When a repeated stimulus is being given again and again and again, what we tend to do, we will not be minding those things. For example, if parents are scolding you people continuously, at some point of time, you don't mind whatever they scold. So those kinds of behavior is called as a habituation. So if somebody is living by a train track, they will get adapted, habituated to it. What is sensitization? Sensitization is the increased awareness. For example, if somebody is bitten by a dog, what is going to happen? What is going to happen? Every time when they see a dog, they feel very much intimidated, and always they are at a heightened awareness. They will have an increased awareness. So these are the types of memory. Then if there is a memory loss, the most common disorder is the Alzheimer's disease. In this, you have to remember two important cytopathological hallmarks. One is the hyperphosphorylated tau proteins and amyloid plaques. So these are two are very, very important. And coming to the language and speech. What is language? It is the method of communication. Speech is the articulation of sounds. For example, language can be sign language also. But whenever you are able to articulate into a sound, it is called as a speech. So verbal language is of hearing and speaking. Written is you are able to read it and write it back. So what are the areas involved? Most of you know that two important areas are involved. One is the Wernicke's area, area number 22, and Broca's area, area number 44 and 45. And another area is the angular gyrus, which is area number 39. And one more area, these two areas we always remember. Wernicke's is for reception. If I talk something, if you are able to understand it, then that is done with the help of Wernicke. And if you are saying that I am able to hear you, sir, we are not able to see the video, something like that, that is done with the help of Broca's area. Broca is for articulation. This is for hearing and talking. But for reading and writing, this can be a potential MCQ, but for reading and writing, we need two more additional areas. What are those two more additional areas? Angular gyrus. So if you read something, it will go to the angular gyrus and then Wernicke's, then Broca, then finally it will go to another area for Exner's. This Exner area is for motor hand coordination. So two areas I have told newly. One is the angular gyrus, another one is Exner's area. So let's summarize it here. Wernicke, we know it is understanding speech. Broca's, we know it is articulation. But for written word, to analyze, understand the written word, we need angular gyrus, that is for perception of written word. It is also called as Dijkstein's area. And for writing, we need another area, that is the Exner's area. So these are two additional areas you should remember. So Wernicke's aphasia, the common aphasia, here it is also called sensory, but because sensation is not coming into the person or receptive or fluent. Why it is called fluent? Because here the Broca is intact and Broca is the one which is responsible for word production. If word production is proper, then he'll talk fluently, but he will not talk sensibly. That is there. And the person will be able to, will not be able to comprehend written or spoken language. He will not be able to understand. In Wernicke, understanding is gone. Understanding is affected. And there will be word salad and neologism. Neologism is production of new words. And in Broca's, what will happen? There will be an expressive, motor, or non-fluent. He will not be able to express, or motor activities are affected, or a non-fluent. Like he will not be able to talk fluently. Here, the comprehension is preserved. That is important. Here, the comprehension is preserved. And the person will have a telegraphic kind of speech. The person will have a telegraphic kind of speech. So coming to the special senses, I'll just discuss the olfaction and taste. Hearing and ophthalm may be covered in their respective lectures. So coming to the olfaction, the smell, the most important thing is it will go to the amygdala. It is the one which is controlling the emotional response to the olfactory stimuli. And it will go to the orbitofrontal cortex. There is what the smell is being consciously discriminated. And it will go for another area. Whenever there is a smell, you will relate to two things. One is that sometimes you feel as if your mother have cooked, so emotional feeling is there. And sometimes this smell will trigger, it looks like I have eaten something like in Pondicherry or something like that. So this olfactory memories will go to the entorhinal cortex, which we have already seen it in the limbic circuit, modified Pappas circuit. And odorant receptors are of G protein coupled receptors, and the ions responsible are calcium ions. So we should know the olfaction has three important things: the orbital cortex, amygdala, and entorhinal cortex. And olfaction, I have already given one MCQ. It is the one which is not passing through the thalamus, exception if they ask. Coming to the taste sensation. Taste sensation, there are 5 different types of taste: salt, sour, sweet, bitter, umami. Salt and sour are ionotropic receptors, ion channels. They're basically ion channels. For salt, the ion channel is ENaC. What is ENaC? ENaC is epithelial sodium channels. ENaC is epithelial sodium channel. Epithelial sodium channels. And what is sour? Sour will go through HCN. This is hydrogen channel. Hydrogen channel. Sour taste will go through the hydrogen channel. And sweet taste, sweet, bitter, and umami. All 3 are GPCRs. That is G protein coupled receptors, which is also called as metabotropic receptors. And the subvariants are T1R2, T1R3 for sweet, T2R for bitter. But more than that, the most important MCQ which is newly introduced is the umami taste. So umami taste, you remember, it is acting through the monosodium glutamate receptors, M-glu receptors. This is the monosodium glutamate receptors, M-glu receptors. Okay, so this is very, very important. This umami is very, very important. If you don't remember the other things, completely. So this is important. So this brings us to the end of central nervous system. Now we will switch on to the renal system. So we'll try to do the most important aspects of renal system. So renal system, this is the general diagram where you guys know that is the glomerulus, Bowman's capsule, PCT, then loop of Henle, then DCT, and the collecting tubule. Then there are 2 different types of nephrons. The one is the cortical nephrons and medullary nephrons. Medullary nephrons are the one which go deep inside the medulla. Even though Bowman's capsule is located in the cortex, they have a long loop of Henle which goes deep inside the medulla. And the most important function for the medullary nephrons is the concentration of urine. Concentration of urine. Whereas the general function for the cortical nephrons is excretion of waste. Majority of the function is the excretion of waste, but still the medullary will be able to concentrate the urine. That is the importance, because urine should be concentrated. Otherwise, if the urine is not concentrated at all, if the medullary nephrons are not present at all, we have to urinate 22 liters per day. So assume like how much intake has to be there. So that is how important the medullary nephrons, even though their quantity is very, very less. And the capillaries here are peritubular capillaries, and they have a special capillary in the medullary nephrons, that is the vasa recta, which we'll study in the countercurrent mechanism. The blood flow O2 and PO2 are high in case of a PO2 oxygen levels are high in case of cortical, whereas it is low in case of medullary. O2 extraction ratio is high because availability itself is less, so it has to extract more and more oxygen. And that is the reason the medullary nephrons go in for an hypoxia easily rather than a cortical nephrons. So coming to the and usually they have, whenever this Bowman capsule capillaries, they have a glycocalyx, heparin sulfate, and glycoprotein. All these are negatively charged. So what is the negatively charged will do? They will repel the negatively charged. And their pore size is very, very small. So whenever a substance is very, very small, less than 1.8 nanometer, they are freely filtered, whatever the charge is. But this 1.8 to 4 nanometer, what will happen is, if they are negatively charged, they will be repelled off because of the substances that I have discussed above, like heparin sulfate. They are not filtered at all. The classical example is albumin. So, but in the disease, whenever their negative charge is eliminated, membrane's negative charge is eliminated, albumin will be the first thing to appear in the urine, causing albuminuria. So if it is positive, it will be filtered because the pore size is still 4. More than 4, whatever the charge is, it will not be filtered. There are 3 important proteins: nephrin, podosin, alpha-actinin. Nephrin, whenever it is mutated, it will lead on to congenital nephrotic syndrome. Nephrin nephrotic syndrome. Then podosin is a steroid-resistant nephrotic syndrome. This podosin is for the steroid-resistant nephrotic syndrome, and alpha-actinin is for the FSGS, that is focal segmental glomerulosclerosis. Then coming to the juxtaglomerular apparatus, they have asked very recent question also. The juxtaglomerular cells works in close association with whom? It works in close association with the macula densa. So the juxtaglomerular cells apparatus consists of 3 important elements. One is the JG cells, juxtaglomerular cells, which is present in the afferent arteriole. Another one is the macula densa, which is present in the thick ascending limb. And third one is the lattice cell. The lattice cell is not of a great importance, but still it is forming the juxtaglomerular apparatus. So this region highlighted over here forms the juxtaglomerular apparatus. So what is the function of juxtaglomerular cells? The juxtaglomerular cells has the ability to release renin. Renin will go and activate the renin angiotensin aldosterone system, and they will cause the reabsorption of sodium plus vasoconstriction. So whenever the BP is very low, hypotension is happening or a hypovolemia is happening, it will try to reabsorb and vasoconstrict with the help of renin angiotensin aldosterone system.
Sir, can you repeat juxtaglomerular apparatus, sir?
Juxtaglomerular apparatus, we have 3 important components. Like this is the apparatus which work together. It consists of 3 important elements. One is the juxtaglomerular cells, which is present in the glomerulus. This is the glomerulus, the red ones. And another one is the macula densa. This macula densa is the one which is present in the thick ascending limb. And one more cell is there which is present in between them, called as the lattice cells. They are called as the lattice cells. These 3 work together. That is why they have been grouped as juxtaglomerular apparatus. When we discuss about macula densa, you will understand like how macula densa is in turn helping the JG cells.
Thank you, sir.
We'll come to that. And next is the renin angiotensin aldosterone system. This chart, all of you know, angiotensin is converted to 1, 2, and aldosterone, I told the function already. And macula densa, what does it do? Now comes the important part. The macula densa, it is present in the TAL, that is a thick ascending limb. It has a very specific channel called as the NKCC. These channels we have to remember, there is no other alternative. NKCC. What is this NKCC is? It is sodium potassium 2 chloride channel. This channel is sodium potassium 2 chloride channel. So whenever the load of sodium potassium 2 chloride is high, what it will do is it will be sensed by the macula densa. When the load will be high, whenever the GFR is high, whenever the GFR is high, what we have to do? We have to reduce the GFR. So that is the function of it. So ideally, whenever the sodium chloride load is high, it will produce the ATP and it will convert to ADP and it will release adenosine. This adenosine will go to the JG cells and they will cause the calcium influx and they will stabilize the vesicles. This is the one place where the calcium will stop the release of vesicles. Whenever calcium is available, I have told myself that it will help in fusion of vesicles and exocytosis. But this is the only place in physiology where the calcium is stabilizing the membrane. That's why it is called calcium paradox. So this increased load will be sensed by the renin, JG cells, and they will reduce the release of renin. When release of renin is reduced, what will happen? Renin, angiotensin, aldosterone system will not happen. If aldosterone is not there, there will not be further reabsorption of sodium chloride because already there is more sodium chloride which is sensed by the macula densa. We don't want to reabsorb more and more sodium, which will be harmful for us. So that is why this feedback is there, which is helping to regulate the levels of sodium potassium. And this is what is called as the tubuloglomerular feedback. This is what is called as the tubuloglomerular feedback. So whenever there is an increase in GFR, what happens? There is an increase in load of sodium chloride and there is an NKCC sensing in. Then they will produce adenosine and there is a decrease in renin. So there is a decrease in reabsorption of water, decrease in reabsorption of sodium. So finally, they will reduce the GFR. So whenever the GFR is increasing, it is getting reduced with the help of this tubuloglomerular feedback. That's how it helps. And what is that's how this sodium chloride is being sent to the impulses to the juxtaglomerular cells to cause them to decrease the release of renin secretion. They are working together in this glomerulotubular feedback. Then coming the Lassus cells, the Lassus cells as such, they don't have much of a function. They also produce a little bit of renin. That's it. Nothing important about the Lassus cells. Then coming to the GFR. What is GFR? All of you know it is the glomerular filtration rate. So the renal plasma flow, the whatever plasma is flowing to the renal system is around 625 ml. But out of this, only 125 ml is being filtered. That is the glomerular filtration rate. And it is filtered at the rate of 125 ml per minute. So there is a concept called as clearance. What is clearance? Clearance is the volume of plasma from which the substance is cleared off. So this clearance formula will help us to estimate the volume of a particular composition. For example, volume estimation of GFR or volume estimation of the total renal plasma flow. All of them will be given by this formula, which is volume is equal to amount of substance by concentration. This is further decoded to the formula of UV by P. How this UV by P came is because amount of substance, when you know the concentration of a substance in urine and you know the urine flow, when you multiply both of them, that will give me the amount of substance. And concentration is concentration in plasma. Most likely for MRB, I don't think this formula will be required, but still have a look at this UV by P. If they are given values, just you have to plug into this UV by P. Then, but they have asked previously also, twice they have asked, what is the GFR measurement? How do we measure the GFR? GFR is measured using two substances. So read the question carefully and answer. If they ask you the gold standard method, what is the gold standard method for measuring the GFR? It is gold standard is inulin. We use inulin to measure the GFR, but inulin is given from outside. We inject inulin to do the GFR. But if they ask you what is the endogenous method of GFR measurement, endogenously produced substances which is used to measure the GFR, that is given with the help of creatinine clearance. So it is around 140 ml per minute. So the GFR here comes as an increased value. So that is the disadvantage. Advantage is it is endogenously produced, whereas inulin is given, should be given from outside. But the disadvantage is the value is overestimation. There is little bit overestimation of GFR. So GFR measurement, if they have asked, then the next question they can ask you, What is the renal plasma flow measuring substance? This RPF is renal plasma flow. What is the substance used to measure the renal plasma flow? This renal plasma flow is measured using a substance called as PAHA, that is para-aminohippuric acid. And whenever they measure it, the value comes around 625 ml per minute. And what is filtration factor? Out of the GFR, how much is being, out of that renal plasma flow, like we saw above, renal plasma flow was huge, but out of that, how much is filtered? So that is given by GFR by renal plasma flow 125 by 65, it is around 20%. Out of the renal flow, only 20% is being filtered. So that's what it indicates. Then coming to the determinants of GFR. GFR is determined with the help of Starling forces. It is pretty simple. Some of the forces are pushing the fluid to the Bowman's capsule. So this is the glomerulus and here is the Bowman's capsule. Some of the forces are pushing the fluid into the Bowman's capsule, and some of the forces are pushing the fluid from the Bowman's capsule into the glomerulus. So whenever any fluid is there, we will have two forces. One is the hydrostatic pressure. It is the water pressure which is created, and water pressure will always push from the blood vessel to the outside. Another one is oncotic pressure. If any protein is there, if a protein is there, what it will do is it will try to suck in the fluid. That's what it is going to do. But we know that none of the protein is filtered. So in the Bowman's capsule, we will not have any protein. So its value will be 0. So hydrostatic pressure in the glomerulus is around 60, which is pushing it out to the Bowman's. Then oncotic pressure is 32. Then hydrostatic pressure of the Bowman's is 18. As you can see here, 60 and 60 is acting one side, then 18 and 32 are acting at the other side. So the net pressure, when you calculate it, one pressure is 0. This oncotic pressure of the Bowman's is 0 because here there will not be no proteins. Here there will not be any proteins. That is the reason it is considered as 0. So when you put the net pressure, it is around 10 mm of Hg. So this is the net filtration pressure and it is towards the Bowman's capsule. Obviously, it should be towards the Bowman's capsule. Then only from the vessel, it will go into the Bowman's capsule for filtration. So coming to the regulation of GFR, there are various methods of regulation of GFR. One is the myogenic response, tubuloglomerular feedback we have already seen, then glomerulotubular balance, then resistance of afferent and efferent arteriole. So coming to the myogenic response, what happens in myogenic response? It is pretty simple. Whenever there is a stretch of the vessel, there will be opening of calcium channels and the vessel will constrict. So stretch is being constricted. So that is the mechanism, auto-regulation. Stretch sensitive calcium channel will open and they will constrict the vessel. That is what happens. Then there is something called as glomerulotubular balance. This is not glomerulotubular feedback. This is glomerulotubular balance. What happens here is, whenever the more and more substances are coming in, the proximal tubule can reabsorb more and more, but this happens up to a certain limit only. Whenever the load in the glomerulus is increased, there is an increased reabsorption from the tubules, especially from the proximal convoluted tubule, because it is the one which will reabsorb maximum amount of substances. Okay. So this is called as glomerulotubular balance. More is coming in, more is being reabsorbed, but up to a certain limit. Then coming to the resistance in the arterioles. The resistance in the arterioles, we have to understand how it affects the GFR. For example, afferent arteriole is very easy to remember. Let's start with that. Whenever afferent arteriole is dilated, I am increasing the size. So more flow will come, more GFR will come. Pretty simple. So whenever afferent arteriole is dilated, more GFR is going to go in. Whenever afferent arteriole is constricted, afferent means input itself is constricted. I am constricting here. So less fluid only will go. So decrease in GFR. Afferent arteriole is very easy. Dilated, increase the GFR, constricted, decrease the GFR. But efferent arteriole is not so easy. That's why they ask the MCQs there. Efferent arteriole, whenever we dilate it, that is easy. If I dilate it, what will happen? All the fluid which will go from here, they will move fast. So there is a decrease in hydrostatic pressure. There should be some pressure for the fluid to be pushed from here to here. If I dilate the efferent arteriole, what will happen? This hydrostatic pressure will be decreased and there will be a decrease in GFR. Then comes the constriction. The constriction has two features. It can be an increase in GFR also, decrease in GFR also. That's why it has been asking questions. So efferent arterial constriction, if the constriction is little less, if the constriction is less, less than threefold or less than 1/3 of the vessel wall constriction happens, what will happen? There is an increase in hydrostatic pressure. So this is the efferent arteriole, and we are constricting a little bit. If you constrict a little bit, what will happen? The hydrostatic pressure is high here, so there will be an increase in GFR. This is the one which happens physiologically. But if I constrict the vessel so much here, there will be a back pressure. So the more and more fluid cannot enter it because of the back pressure. So the blood flow itself will reduce. Plus, more and more oncotic substances will be in this settlement because of the stagnation that is happening. What will happen? More and more oncotic substances will there, and they will suck in the fluid towards them. The major reason being the back pressure, because of which the blood flow, if I constrict one area, what will happen? There will be creating of back pressure here, and there will be less fluid coming in. So this blood flow itself will reduce, and there is an increase in oncotic pressure, leading on to decrease in GFR. Physiologically, constricting the efferent arteriole is good to increase the GFR, but pathological condition will constrict it so severely that there will be a decrease in GFR. This you guys have to remember. Then comes the important part, that is the tubular transport. These are the important notes of the tubular transport. What you have to remember is the proximal tubule does maximum of reabsorption. It does 2/3 of sodium chloride, water 2/3, potassium, urea, calcium. All of them 2/3 of the quantity, like 75%, more than 75%, 60, so around 66% is being absorbed in the proximal tubule itself. And sometimes the examiner might ask you a question, H2O is reabsorbed maximally where? H2O is reabsorbed maximally where? In the presence of ADH. All of us will think too much and think that ADH, if it is there, it will be reabsorbed maximum in the collecting tubule. But see here, already 2/3 is absorbed in the proximal tubule itself. So whether the presence of ADH is there or ADH is not there, always maximal reabsorption of water happens in the PCT only. And rest things we have to remember is 80% of phosphate and bicarbonate is reabsorbed in the PCT. Then 100% of glucose is being reabsorbed in the PCT. Glucose complete reabsorption happens here. Whenever the levels go too high, then only it will be sent in the urine. Then maximum magnesium reabsorption. This is the exception which is not done in the PCT. It is done in the thick ascending loop of Henle. These are like facts you have to remember. Maximum magnesium maximum. We will see in the discussion also, further discussion also. In thick ascending loop of Henle, whenever we are discussing, there will be too much of reabsorption of the fluid, reabsorption of magnesium will happen there. So coming to the sodium transport we will discuss in various levels. First, coming to the PCT, here few things we have to remember. Sodium is transported along with glucose. Sodium is transported against the H+. Sodium is transported with the amino acid. Here, most important channel is sodium hydrogen exchanger. Sodium hydrogen exchanger will help us to reabsorb more and more of sodium in the PCT. And I told you 2/3 of sodium reabsorption happens in the PCT only. This is the most important channel. Not only that, the angiotensin also acts in the sodium hydrogen exchanger. This is important. Now PCT is done. In PCT, just remember this one channel, sodium hydrogen exchanger. Then coming to the thick ascending loop of Henle. In thick ascending loop of Henle, we have already discussed one important channel for sodium reabsorption, that is the NKCC. Where does it being sensed? It is being sensed by our macula densa. So this we have already discussed. And thick ascending loop of Henle, this NKCC, whenever this gets mutated, there will be a Bartter syndrome. There are three most important syndromes: Bartter, Gitelman, and Liddle syndrome. If you remember these three syndromes, that is more than sufficient for the tubular reabsorption. So whenever the sodium is coming out, it will be sent out with the help of number 2 I have written there. It will be sent out with the help of a ROMK channel. Whenever ROMK channel is mutated, it is Bartter type 2. And there is another channel which is in the basolateral side, which is a chloride channel, CLCK. If it is mutated, it is Bartter type 3. And there is a protein in this CLCK that is called Bartin. This Bartin protein is also present in the ear. So how will the patient present? The patient will present with Bartter syndrome along with deafness. That is the type 4. So this is the important. And I have told you in thick ascending limb, magnesium reabsorption is maximum. How it is getting into maximum reabsorption? Because this K plus starts accumulating more and more positive charge, because of which the positively charged ions like the magnesium and calcium are being sent into the blood. So what are the features of Bartter syndrome? Bartter syndrome, if it is affected, this channel is affected. Just remember, this channel is affected. So sodium reabsorption will come down because it is a sodium channel. So hypovolemia. And if sodium is not reabsorbed, along with it, potassium is also not reabsorbed. So everything will be sent into the urine, hypokalemia. Chloride is also not reabsorbed, hypochloremia. Magnesium is also not reabsorbed. For magnesium reabsorption, we need this positivity. This channel is affected, this positivity is also affected. So hypomagnesemia. And next thing that can happen is hypercalcinuria. Calcium will be excreted in the urine more and more. Why? Already we have seen here magnesium and calcium. Both of them, they cannot enter in, so they will be excreted in the urine. We use the term hypercalcinuria, not hypocalcemia, because calcium hemostasis can be done from the bone with other hormones. So we are talking only about the urinary levels. So Bartter syndrome will be hyperchloremic, hypercalcinuria with nephrocalcinosis. This metabolic alkalosis, I will explain it a little later after going to the next segment. So you just remember this channel, NKCC, and rest of the features you can identify. We'll summarize it at the end also. This is very important. So we'll summarize it at the end also. Now coming to the DCT, distal convolutal tubule. I would suggest you to watch this part of the video again after in the recording, because this is very important also. This DCT will have a simple channel, that is sodium chloride channel. So this is called as NCC. If it is affected, it will lead on to Gentleman syndrome. Just remember, gentleman goes to NCC, national NCC, gentleman usually go. So this is the one which is mnemonic, which can be used to remember. Gentleman, the NCC channel is affected. So again, in the similar manner, here also the potassium will come out through the ROMP. Again, magnesium will be reabsorbed through the transcellular route. Same things is happening. But only one change that will be different from that of a Bartter syndrome is that what will happen is in the basolateral side, this is an exception. In the basolateral side, what is happening is sodium is coming in and calcium is being exited. So what will happen? This channel is affected. So this channel is affected. So if this channel is affected, inside sodium will fall. If inside sodium will fall, sodium will try to come through this channel more and more. This channel will become hyperactive. So what is happening to the calcium? This calcium is being sent into the blood. It is sent into the blood. Previously, what was happening in Bartter? Calcium was being sent into the urine. Here the calcium is being reabsorbed. So the only change in feature will be here there will be hypocalciuria. Whenever you compare a Bartter syndrome with that of a Gentleman syndrome, in Gentleman there will be hypocalciuria, whereas in Bartter there will be hypercalcinuria. That is one of the most important differentiating feature between these two. Then coming to the next segment, that is the collecting tubule. What is the channel for sodium that is present in the collecting tubule? It is nothing but the ENaC channel. ENaC channel, whereas the sodium is being absorbed. So usually we were studying what happens to the channel if it is getting affected. But in the ENaC channels, there is not much of a syndrome that is where the ENaC channels are getting affected. There is one syndrome where there is a gain of mutation. There will be gain of mutation of ENaC channels. That is called as Liddle syndrome. Liddle syndrome is for the gain of mutation. Whenever this sodium is entering in, again the potassium from the basolateral side, the sodium potassium ATPase will come out in exchange for sodium. If more and more sodium is reabsorbed, more and more potassium will come. After that, what will happen is, if more and more sodium is further reabsorbed, then hydrogen will be exchanged for the sodium intake. So we have to remember this very important point. Whenever there is an ENaC channel hyperactivity, more and more potassium will come out and more H plus also will come out. That is what is going to happen. So what will be the features? There will be increase in sodium reabsorption. Here it is a gain of mutation. So ENaC is activating more. So there will be hypertension. Both in Bartter as well as Gentleman, we were seeing there is a hypotension or a hypovolemia, but here there is a hypertension. That is the differentiating feature. And H plus is exiting, causing hypokalemia. And if more and more is reabsorbed, what I said, H plus also will exit, which is causing the metabolic alkalosis. Now we will go back again to the Bartter syndrome. Here also it is written metabolic alkalosis. What is the reason is, if the sodium is not reabsorbed here in the thick ascending limb, then it will go to the next segment. Then finally it will go to the collecting tubule. Like finally it will go to the collecting tubule. We have ENaC channels in the connecting tubule. So what the ENaC channel will do? The ENaC channel will go for hyperactivity in case of a Bartter syndrome also, because of the increased load that is being sent to the ending segments. So that is why the metabolic alkalosis will happen in both of the disease. Now, don't worry about all these things. Now we'll summarize it so that it is very, very easy. So first thing is Bartter NKCC is affected. Gentleman will go to NCC. Little gain of ENaC. Okay. Little is very simple. It will cause hypertension. Nowhere hypertension will happen. It will cause hypertension. The differentiating feature between Bartter as well as Gentleman is, in Bartter there will be hypercalcinuria. Urine, there will be too much of calcium in the urine. Whereas in Gentleman there will be hypocalcinuria. So these are the differentiating features. So if you remember these key points and the channels, that is more than sufficient. For pharmacologically, loop diuretics will act on NKCC, thiazide will act on NCC, then amidone will act on the ENaC channels. This you will read it in pharmacology also again. So while reading pharmacology also, try to come back to these slides, because I have compiled it in a much easier way to understand it. So these three syndromes, you can read it from here, not only for this exam, in general also. Then coming to that was the transport of sodium. Now coming to the transport of glucose. In glucose, most of the glucose, or like almost all of the glucose, is absorbed in the PCT with the help of a channel SGLT2. And in the basolateral side, for transporting into the blood, we need GLUT2. Both are 2, SGLT2, there, here GLUT2. And there is a transport maximum of glucose for 375 milligram per minute, which comes to around 300 milligram per deciliter. So whenever the blood glucose level goes beyond 300 milligram per deciliter, then only we should see it in the urine. But naturally that does not happen. Whenever we see diabetic patients, even at 200 milligram levels, they are urinating glucose in the blood. So why this discrepancy is happening? My transport maximum is saying it should perform till 300 milligram per deciliter. But my actual threshold is just 200 milligram. Why does this happen? Is because not all the nephrons will function at its fullest capacity. So this difference between the actual and the relative, had it been 300 milligram, we might have eaten more sweets also, because it can handle it more and more reabsorption. But again, other disadvantages of diabetes will be there still. This is just the renal part. So this difference between the actual and the real world value, actual and the threshold maximum, is called as the splay, because all the nephrons are not functioning to their maximum levels. Then reabsorption of water, it is just most of the water is reabsorbed in the 60 to 70% in the PCT, rest in the DCT and CT in the presence of ADH. So it is very easy to remember in this diagram. Reabsorption of water in PCT, aquaporin 1, both in the lumen side as well as in the basolateral side. Whereas in DCT, it is 2, 3, 4. 2 is in the luminal side, 3, 4 in the basolateral side. Then coming to potassium, the low diet potassium, everything will be reabsorbed, only 2% will go into urine. But if the person is having high potassium diet, remember this DCT, it can cause secretion also. It can cause secretion of potassium also, to eliminate it, because high potassium levels are very, very dangerous to the cardiac system, which we have already seen it. Then coming to the countercurrent mechanism, just remember two important points. One is the countercurrent multiplier and countercurrent exchanger. Exchanger is vasa recta. Rest whatever is given, that is the multiplier. So for example, thick ascending loop of limb of Henle, collecting duct, descending loop of Henle, thin ascending loop of Henle. Out of this is the least important. So these are the most important. Above three are very important: thick ascending limb, collecting duct, descending loop of Henle. If the question is asked, all of the following are part of countercurrent mechanism except, then you can go for thin ascending limb. If the question is asked, all of the part are countercurrent multiplier except, then go in for a vasa recta, because vasa recta is just a countercurrent exchanger. It is not a multiplier at all. Then the most important channel involved in countercurrent is also NKCC. What is the mutation? If the mutation happens, it is called Bartter syndrome. The most important ion responsible, please pay attention here, it is urea, not sodium, not chloride. Why? Because the human kidneys can concentrate up to 1200 milliosmoles only. Out of this 1200, 600 is contributed by NKCC. So in NKCC, we have sodium also and chloride also. So sodium contributes 300, chloride contributes 300. Rest osmolarity, that is the hyperosmolarity in the kidney, is caused by urea. So single ion, if they ask, ion, actually urea is not an ion, you can say single substance responsible if they ask, then it is urea. But the channel, most important channel is the NKCC channel. So these are the MCQs which has been highlighted here. And coming to the cystometrogram, it is the reference between the bladder volume and the bladder pressure. So what happens is whenever the bladder is filling, the pressure keeps on rising up to a certain limit, where the first urge for micturition happens. It is around 150 ml. This first urge for micturition happens in the 150 ml. After that, we don't feel micturition at all for a very long time. What happens here? Here it is a flat curve. What is the reason for this flat curve? Here the volume of the bladder is also increasing. The bladder is getting filled. Here it is again, the Laplace law says that the pressure is equal to twice the tension by radius. But ideally, if the tension increases, the pressure should increase. But here, tension is also increasing as well as the radius is also increasing. So in this diagram, if they ask you which part follows the Laplace law, it is the part 1b which follows the Laplace law. Which part Laplace law is applicable? It is 1b. They can ask reverse also. In 1b, which law is applicable? It is the Laplace law. Then after that, we cannot hold it. We'll feel a severe micturating feeling, and definitely we have to urinate. So this brings us to the end of renal system. Rest, everything is a very small thing only. We can complete in half an hour maybe. Can we take a 5 minutes break?
Yes, sir.
Okay. So is it okay if it crosses 11 o'clock? Otherwise, you can see it in the recording also. I'll try to give the most important hints of the rest of the chapters also. I'll just share the screen. Okay, can you hear me? Okay, yes, okay. Thank you. So coming to the GAT again, you will read it in anatomy also, most of the structures of GAT. So basically, I'll just skip through the few slides. So it is mucosa, submucosa, muscularis mucosa, and serosa. Here we have to remember few important things only. First is the submucosa. The submucosa will have the submucosal plexus. This is also called as the Meissner's plexus. Submucosal plexus, remember, S is for the secretions. It is for the GI secretions. Then in between the muscularis layer, there is an inner circular and outer longitudinal layer where we have the myenteric plexus. Myenteric plexus, as the name indicates, myenteric means muscle. So contraction, it is going to happen. That is why it is located in the muscular layer and they were helping in the movements in the GAT. This Meissner's and myenteric plexus, they can act individually. They don't have to concentrate on any, they don't have to depend upon any external sources of innovation. So that's why they are called as the little brain of the gut. So coming to GAT motility, we always have the electrical motility and the mechanical activity. The electrical activity here is called as the BER, or the basal electrical rhythm, and it keeps on fluctuating between -45 to -65. And here also there is a downstroke and an upstroke, like a depolarization and repolarization. Depolarization happens with calcium. In cardiac muscle SA node, and here in the GAT it happens via calcium. Then efflux, always potassium. Efflux, there is no need for confusion, it is always potassium. So this is a spontaneous rhythm, and the pacemaker here is the interstitial cells of Kajal, and it is primarily located in the inner circular muscle layer of the proximal body of the stomach. And this BER does not produce any contractions. They don't produce any type of contraction. They have to be super added with some influence. Then only they will produce a contraction. And acetylcholine, whenever it is super added or acetylcholine is released because of any nerve impulses or intake of food or anything, they will produce a spike potential and they will cause contraction. Then reverse of acetylcholine, if epinephrine is there, they will cause relaxation. Acetylcholine contraction, then epinephrine relaxation. Then this is the, then coming to the mechanical activity. Mechanical activity happens during fed state also, as well as in fasting state. In fed state, there happens peristalsis and segmentation. One of the most common mistakes is most of us think that peristalsis is the dominant motility, but it is not, because peristalsis moves the food from one portion to the another. But there is one more important thing that should happen is food should be mixed, like mixed from all the sides, and it has to be reabsorbed. For that we need time. So segmentation is the one which is the dominant motility in the GAT during a fed state. During a fasting state, it is MMC, which is called as migratory motor complex. So coming to the peristalsis, peristalsis is a propulsive movement. So whenever food reaches a particular part, what will happen? It will become stretched. Whenever it is stretched, it sells the impulse from proximally also and distally also. In proximally, what I should do? I should contract. Distally, I should relax so that food can be moved. So there can be many multiple questions here. Whenever there is a stretch, the myenteric plexus acts upon, and the first neurotransmitter that is released is serotonin. At the place of the stretch, serotonin will be released. This serotonin will give impulses front as well as back. Behind, or the proximal portion, there will be contraction because of ACH. We already know ACH is the one which is contracting the GAT. And substance P. Next is substance P. So you have to remember all this substance, ACH, substance P. Then for the relaxation, we have ADP, nitric oxide, and vasoactive intestinal peptide. So this is the peristalsis. The peristalsis in the large intestine happens in the case of mass movement, to look like a mass movement. That is the reason whenever food is there inside the GAT, like in the stomach, then also we will have some colonic movements. Many people, they just go for the washrooms immediately after eating. That is because of this gastrocolic reflex, because food in the stomach can create the mass movement in the large intestine. And this happens in children because in children, this mass movement is very huge. Immediately when they are fed, they are going to go for potty. That is their only thing that they are going to do. Then segmentation, I told you, it is the one which is going to crush the food in all sides for reabsorption of the nutrients, and the it is gives the time for absorption and digestion. So that is why it is a dominant motility. And in the stomach, already we have discussed receptive relaxation is a feed forward kind of relaxation. Whenever food is there in the mouth itself, it will start relaxing. Another one is called as adaptive relaxation. This is a feedback kind of relaxation. So this is a feed forward. This is a feedback, because once the food comes, it is relaxing. That is a feedback mechanism. Then these are the fed state motility. During the fasting, what happens is migratory motor complex. So basically, it is preparing the stomach for the next meal. So the hormone here is, just remember M for M, motilin. It is the hormone which is produced by the MO cells of the stomach. What is their function? They are going to clear the stomach for the next meal. So their main function is housekeeping. During this, the gastric juice is also produced. It's like it is like brooming as well as sweeping with water. Gastric juice is also produced, and they have as the duration ones, like in 90 to 120 minutes after meal. In a similar manner, in non-REM REM also, the cycle happens every 90 minutes. So both are 90 minutes only. The answer for both of the questions are 90 minutes only. So coming to the motility disorder, one classical disorder is achalasia cardia, where the lower esophageal sphincter is not relaxing. The reason being increased ACH, and in barium enema, radiologists will find out a bird beak appearance. Bird beak appearance. And what is the treatment? Here it is constricting, the lower esophageal sphincter is contracted. So we have to relax it. What we can do is we can give in Botox. Botox will stop the ACH fusion. This botulinum toxin has been used for GAT, achalasia cardia, as well as wrinkles and facial beauty also. So ACH fusion will happen, and the surgery done for this is the Heller's myotomy. Heller's myotomy is the surgery done for achalasia cardia. Whereas another disease, Hirschsprung disease, it is called aganglionic megacolon. What happens is the neural crust which has to migrate, it is not migrated. So both myenteric as well as Meissner's plexus will be absent. And now newly they have identified this thing, that is there is an endothelin B receptor which is a defect, which this endothelin B receptor is responsible for the migration of neural crust. And they have found that recently that this endothelin B receptor is defective in this aganglionic megacolon person. And what is the treatment? That ganglion does not have any neurons at all, so food will not pass through it. So only the treatment is resection and anastomosis. That is the treatment. Coming to the GI hormones, three most important hormones we should know: gastrin, cholecystokinin, and secretin. Gastrin, as the name indicates, it is going to produce gastric juice. So what happens whenever there is a peptides, which is the most potent stimulus for gastric acid secretion, it is present, it will go and stimulate the parietal cells as well as the chief cells. The parietal cells will produce the HCl. First thing is it will be sensed by the gastric G cells. They will produce the gastrin. This gastrin will go and in turn stimulate the parietal cells. They will stimulate the parietal cells and produce the HCl. And this HCl in turn inhibits the gastrin. It is a kind of negative feedback mechanism. So what is the main function of gastrin? As I told you, it is gastrin is the hormone which produces the gastric juice. So this parietal cells will produce the HCl. And the intrinsic factor, another one important factor is intrinsic factor, which is produced by the same parietal cells. So this intrinsic factor will combine with vitamin B12 and it is reabsorbed in the ileum. If there is problem in intrinsic factor, if there is problem in vitamin B12 or a ileal resection has been done, in all of it, we will have a kind of anemia which is called as megaloblastic anemia, because the maturation of RBCs will not be properly there. Then it also stimulates the C cells to produce pepsinogen, that increases the motility of growth of the GAT. So all these things it is going to increase. Coming to the disease of this region, what happens whenever there are antibodies against this parietal cells? So whenever there are antibodies against this parietal cells, two things will happen. One is there is decrease in HCl, another one is decrease in intrinsic factor. Decrease in HCl, decrease in intrinsic factor. So because of this, there will be an increased infection of the stomach. HCl is a very good hormone which is preventing the infection. So because of it, it will be increased. So there is a decrease in vitamin B12 also, which is leading on to the pernicious anemia. So it will be a maturation defect where the macrocytic cells or megaloblastic anemia, red beefy tongue will be there in case of pernicious anemia disorder. This pernicious anemia is one which is having the parietal cell antibody defect. Second thing is Zollinger-Ellison syndrome. It is a gastrinoma. So what is going to happen? There is too much production of gastrin here, but how will we find out is because there is too much of gastrin, too much of HCl will be secreted. Naturally, what will happen whenever there is too much of HCl, it is going to go and inhibit the gastrin. But here it cannot inhibit the gastrin, so the levels will be very, very high. So both the levels are high. That gives a clue for us that it is Zollinger-Ellison syndrome, ZES. Then second hormone, gastrin is done. Now CCK. CCK, all of us know, most important function is contraction of gallbladder, second most important function. Most of us think that is the most important function, but primary function is increasing the pancreatic secretions. And for this also, the most important stimulus is the peptides. CCK will act on the CCK-A receptors. So what it will do? It will cause contraction of the gallbladder, relaxation of the sphincter of Oddi. So basically, all the secretion has to reach here. Then contraction of the pyloric sphincter, because it should not be going back into the stomach. So contraction of the pyloric sphincter, increase in intestinal motility, growth of pancreas, augment secretion of secretin. This secretin and CCK are like friends. Both of them will help each other. Here we have to understand two things. The pancreas will have two parts. One is the acinar part, another one is the duct part. Here, this acinar part is responsible for pancreatic enzymes, and that is stimulated with CCK. Whereas the ductal part is responsible for the bicarbonate secretion, and that is primarily done by secretin. And we have to understand two important terms. One is the cholagogue and another one is cholorectic. Cholagogue means it is the substances which is contracting the gallbladder. So what is the most important substance which is concentrating gallbladder? It is the CCK. Then cholerectic, these are substances which increases the bile products. That is the bile salts. Example is bile salts. Then coming to the next hormone, secretin. Secretin is the first hormone that is identified, and I have told you already its function. It is the increasing the bicarbonate, whereas CCK is the enzymatic part. Secretin is increasing the bicarbonate part. It augments the CCK. They are both friends. They will help each other. Then GIP. This hormone was previously called as gastrin inhibitory peptide, but right now it is called glucose-induced insulinotropic factor because its physiological function is to produce insulin. So please remember this GIP. It can be asked as a question because it is a glucose-induced insulinotropic factor. Whenever it is given in supraphysiological levels, then only it is inhibiting the gastric secretion. But in physiological levels, it is increasing the insulin levels. This is very, very important. Then GI secretions consist of saliva, which is hypotonic. So we'll talk about some of the facts. Rest everything is isotonic. Only saliva is hypotonic. So that we have to remember. Most alkaline, if they ask, most of the time pancreas will be given in the answer. But just in case if Berners gland is given, please go for Berners gland because it has a secretion of pH around 8.3 or 8.5. So it is highly alkaline. Go for that answer. Most acidic, it is pretty simple. Gastric juice is the most acidic. Then potassium, it is maximally secreted by the saliva, and maximal concentration C for C is in the colon, least in the bile. So whenever potassium is least, there sodium will be maximum. In a similar manner, whenever potassium is maximum, there the sodium will be less. So remember one, potassium, then sodium can be easily matched. Potassium, maximal secretion in saliva, concentration C in C, colon, least in the bile. Then saliva is one area where both the sympathetic as well as the parasympathetic will increase the secretion. Saliva has just one enzyme called salivary amylase, which will produce the ptyalin, which is also called ptyalin. It is just for the simple carbohydrate digestion, but major digestion happens due to the pancreatic enzyme. So coming to the important part in the GIT, that is the gastric glands. The gastric glands are present in the cardiac area and major gastric glands and other gastric glands. The major gastric glands are the oxyntic cells, that is the parietal cells, and chief cells, which we have already discussed. And other glands are G cells and D cells. G cells will produce gastrin, we have already seen. D cells will produce the somatostatin. Then coming to the acid secretion. For acid secretion, what is the end product? We need H and Cl. So H, to produce an H, we always have a universal reaction. It comes from CO2 only. CO2 plus H2O will give H2CO3, which in turn will give H plus and bicarbonate. So this H plus will be moved out. Now this bicarbonate is available, which will be exchanged for the chloride. This is called as anion exchanger, which is very similar looking equation to that we see in the respiratory system. And chloride is being sent out. The chloride is being sent out via chloride channel. So this is the equation. And the most important channel here is hydrogen potassium ATPase channel. Hydrogen is going out, potassium is coming out. So again, now we can easily design the drugs because we know what are the stimuluses that is produced. Three important stimuluses are there for acid secretion. One is the ACH, then gastrin, then histamine. This ACH will act on the M2 receptor, muscarinic 2 receptors. Then gastrin will act on the CCK-B receptors because this receptor will mimic the CCK-A receptor of the cholecystokinin. Then histamine will act on the H2 receptors. With this knowledge, we can easily design the drugs. If we give an H2 receptor blocker, obviously it will block it, and then there will be some reduction in acid secretion. That is the ranitidine. Whereas if the proton pump itself is blocked, that will be more effective. That are called as proton pump inhibitors, which is nothing but a rabeprazole and omeprazole. If the acid is already secreted, then we can use the antacids. Remember these three important stimulus: ACH, gastrin, and histamine. All of them are friends, and all of them will increase the production of other things. Pancreatic secretion, there is nothing much. The pancreatic amylase and lipase will digest the carbohydrates and lipids. And bile salts, I already told you, it is the most potent cholerectic. So this we have to remember. Then coming to some of the facts in endocrinology. So endocrinology, again, you will be studying in medicine also, but some of the important points I'll be discussing in this video. So first thing is the hypothalamus. We'll start with hypothalamus and move on to every individual organ. The hypothalamus, I already told you, we have the arcuate nuclei as well as the supraoptic and paraventricular nuclei. Supraoptic and paraventricular nuclei, they will produce ADH and oxytocin. Hypothalamus is the one which is producing this posterior pituitary hormone. Then what is the job of posterior pituitary? The posterior pituitary does not produce any hormone. It just secretes these two hormones. So these are hypothalamic hormones exclusively. Whereas anterior pituitary, they will receive many of the influences from the hypothalamus, but they have their own hormones which are to be produced. So first, posterior pituitary hormones we'll discuss. That is the hypothalamic hormone, that is the antidiuretic hormone, and the antidiuretic hormone and oxytocin. So first, antidiuretic hormone. So what it is going to do? It is going to stop the diuresis. Basically, it is going to increase the reabsorption of water. It is also called as vasopressin because it has some vasoconstrictor effect. So it is basically going to insert the aquaporins in the collecting duct and the collecting tubules. If it is defective, what will happen? More urination will happen. The diuresis will keep on happening, and they will cause diabetes insipidus. And diabetes insipidus is of two types. One is the central, whenever there is an ADH deficiency. Another one is called nephrogenic. Here ADH is completely fine, but ADH is not able to act on the kidney. So ADH deficiency and ADH insensitivity will be there. So what is the treatment for it? If central defect is there, then obviously give desmopressin, which is a vasopressin. Vasopressin is defective, we are just giving vasopressin. Then in nephrogenic, it is very fascinating that thiazide diuretics have improved the condition of nephrogenic diabetes insipidus. Ideally, we should not give a diuretic, but thiazide diuretic, somehow it was proving to be efficient. There is an increase in loss of water, hypovolemia, hypotension will be there. Here, urinary osmolality will be reduced because every water is going out, but plasma osmolality will be increased because of the elimination of the too much of water. Coming to oxytocin, it can act on the breast tissue to cause milk ejection, whereas milk production is done with, if the question is production is done with prolactin. Then uterus, it helps to propel the sperm up as well as for the parturition mechanism. And in corpus luteum, it helps to cause the luteolysis. These are the functions of oxytocin. Then hypothalamus and pituitary hormones, all of you must be knowing it. I want to stress on one fact: whenever the connection between hypothalamus and pituitary is cut, all the anterior pituitary hormones are decreased except one hormone, that is the prolactin. Because normally prolactin is kept inhibited. Prolactin inhibitory hormone keeps the prolactin inhibited. But if there is a lesion here, what will happen? The inhibitory effect is gone. So more and more prolactin will be produced, leading on to galacturia. If the connection between hypothalamus and prolactin is, pituitary, anterior pituitary is gone, only one hormone will be increased, that is prolactin, rest everything will come down. Then coming to the anterior pituitary hormones, that is the growth hormone. It has both direct as well as indirect actions. Direct action, obviously, the name itself says it is a growth hormone, so it increases in growth, and it is anti-insulin. It acts as an anti-insulin, and it will cause lipolysis. This has been asked as one of the features of growth hormone direct action, lipolysis, and it will convert the pre-chondrocyte to chondrocyte. Indirect action, how does it do? This growth hormone will go into the liver to form the insulin-like growth factor 1 and 2. And insulin-like growth factor, so it acts like insulin, but direct action is anti-insulin. That is important. This insulin-like growth factor, they can act like insulin. Then it will get converted the chondrocyte into a mature bone. And growth hormone, we talk a lot about growth hormone for the growth, but for the fetal growth, it is the thyroid hormone which is very, very essential than the growth hormone. And growth hormone will be stimulated by stress conditions. For example, hypoglycemia, starvation, exercise. So these are stress conditions. Then NREM sleep, inhibited by glucose and REM sleep. Disorders of growth hormone, it is pretty simple. Dwarfism is there. Then if there is a receptor defect, growth hormone is completely normal, but the receptors are insensitive. That is specifically called as the Laron dwarfism. Laron dwarfism. How will we identify it? Here there is an increased growth hormone or normal growth hormone, but growth is not happening. In case of dwarfism, we can give sermorelin, which is like a growth hormone stimulant. Then if it is increased, it can be increased in children also, it can be increased in adult also. It is increased in children, it is called gigantism. So what will happen? From childhood, they are growing and growing. So extremely tall, all organ size increase proportionately. But if it is happening in adulthood, there will be a disproportionate growth, which is called acromegaly. Because they are already, their bones are fused, they will have a prominent jawline, which is called as prognathism. Those kind of predominant features will be there. What is the treatment? In both of it, we have to suppress the growth hormone, which is a very good suppressing hormone. Somatostatin analog, which is an octreotide, can be given for an increase. For a decrease, sermorelin can be given. But for a receptor defect, not much of treatment options are available. Then the dwarfism can happen even with pituitary as well as with thyroid. In pituitary, what will happen? There is a decrease in growth hormone and overall growth reduction. But in thyroid hormone deficiency, one thing that can happen is mental retardation. Mental retardation can happen because thyroid is very, very essential for the development of the central nervous system myelination. And the infantile features also will be staying. Then coming to the prolactin, it is just the production of milk. And sometimes there is a severe necrosis immediately after pregnancy, like postpartum. That is called Sheehan syndrome. In this, what happens is there is a direct injury to the pituitary itself. Here the pituitary is affected, so even the prolactin will be reduced. The mother will not be able to feed the baby properly, and it is a little devastating condition. It can be very serious condition also, because all the pituitary hormone levels will come down. Then coming to the next hormones, that is the FSH and LH. As the term indicates, FSH is for the ovarian follicular development in females and Sertoli cell development in males, whereas LH, luteinizing, so it is going to cause the ovulation first. Then corpus luteum survival, that's why it's called luteinizing hormones. Corpus luteal survival also it produces. And remember, in males, L for L, it acts on the Leydig cells. Leydig cell is going to dig the testosterone. It is going to produce the testosterone. That we have to remember. And there is one syndrome where there is hypopituitarism along with anosmia. It is called as the Kalman syndrome. This again, you will read it in medicine also. Then coming to the thyroid, thyroid predominantly we know that it is the thyroid hormone, but other than that, there is a parafollicular C cells also. The parafollicular C cells also is there, which is producing the calcitonin. The thyroid hormones which are produced from the follicular cells. This calcitonin, we will read it in calcium homeostasis. It is nothing but a calcium lowering hormone. Then T3 is the active form. It has low half-life and less in quantity. But T4 is not an active form. Its half-life is more and it is in bound form. So this can be converted into the T3 as and when required. So the levothyroxine that we prescribe is nothing but a T4 composition, because as and when required, it will be getting converted to a T3, because we don't want them to give tablets again and again. So this is how the features are. Then coming to the thyroid formation, First iodine trapping happens, then iodination happens, then thyroglobulin reaction, then stored form. More than that, there is a protein which is involved in this mechanism of iodination, like bringing the iodine outside, transport of iodine to the exterior. So this protein is called as the pendrin, and whenever this protein is affected, usually there is an associated ear deafness, like we see in saw in Barter also. Usually here the thyroid disorder along with the deafness, it is called as Pendred syndrome. It is called as Pendred syndrome. Most common cause of thyroid underdevelopment is iodine deficiency, and functions of thyroid, it increases all the motility factors, GAT, CVS, CNS firing. So it is basically increasing all the metabolism, and it is universally catabolic hormone which destroys carbohydrate, proteins, and fats. So that's what it happens. Then in case of hyperthyroidism, features most of you would be knowing it, and one classical feature is there is weight loss in spite of good appetite and weight gain in spite of poor appetite. This is one classical feature which will happen in case of hyperthyroidism. Rest in hyperthyroidism, diarrhea, increase in heart rate, heat intolerance, and hyperactivity will be there. Whereas hypothyroidism, motility and everything is reduced. For constipation, decrease in heart rate, cold intolerance will be there. And for thyroid storm, the levels of T4 and T3 are going to be very high, and it will cause a severe form of tachycardia. When this question is asked, please don't write anti-thyroid drugs as treatment. First, we have to reduce this tachycardia, which is done with the help of a beta blocker like propranolol. This is very, very important. It has to be done with a beta blocker like propranolol. And coming to the adrenal, we have the cortex as well as the medulla. Adrenal medulla is just like a sympathetic system. Epinephrine is produced a lot, and a tumor of adrenal medulla is a very dangerous tumor, pheochromocytoma. Here the person's sympathetic activity, heart rate, mental activity, everything is going to be at a high state, and his mental judgment will be affected, and they will be in a severe anger issues. So that is the tumor of adrenal medulla. Whereas the cortex, it has GFR, like three parts: glomerulus, fasciculata, and reticularis. And GFR is going to produce mineralocorticoids, glucocorticoids, and sex steroids. Sex steroids, primarily the testosterone, it is responsible for the axillary as well as pubic hair growth. Now we'll talk about the mineralocorticoid and glucocorticoids. Mineralocorticoid is the aldosterone, and it is going to act on the ENaC channels. So whatever feature I have discussed in Liddle syndrome, that will be the feature with hyperaldosteronism also. Conn syndrome. Hyperaldosteronism is called as Conn syndrome, and whatever feature we have discussed in Liddle syndrome, the same will happen, but the reason is different. There was a gain of ENaC mutation, but here aldosterone, which can activate the ENaC, is increased. Both are same, but only the reason is different. So exact similar features will be there in Conn syndrome as well as the Liddle syndrome. And coming to the corticosteroids from fasciculata, corticosteroids, all of us know its function, like skeletal muscle catabolism, it happens. Then protein catabolism, fat lipolysis. That's why in Cushing's patient, as you can see from this diagram, there is fat deposition here and there, and there will be poor muscle development, poor wound healing will be there, because the general action of corticosteroids is anti-inflammatory and anti-allergic, and it is antipyretic also. Whenever there is a severe glucocorticoid excess, the person will undergo a Cushing syndrome. And these are the classical features of a Cushing syndrome, where the cortisol levels are very high. Nowadays, the most common reason for Cushing syndrome is the exogenous administration of corticosteroids. Some of the patients, they take it for multiple years, 5-10 years, they will be taking the tablets of corticosteroids. And the next one is primary adrenaline insufficiency. There are three diseases we have to remember. First one is the Conn syndrome, where there is hyperaldosteronism. Second one is glucocorticoid excess, Cushing syndrome, and third one is primary adrenaline insufficiency. The name itself is as adrenaline insufficiency, so Addison's disease. So here what happens? All the glucocorticoid is decreased, all the mineralocorticoid is decreased. If mineralocorticoid is decreased, what will happen? Sodium reabsorption will be affected. So sodium and water loss will be there. So severe volume loss will be there. So they will go in for a shock called as Addisonian crisis. And one of the key feature that will be given is the hyperpigmentation. Why hyperpigmentation happens? In adrenal insufficiency. In adrenal insufficiency, cortisol is not produced. So cortisol usually gives a negative feedback to ACTH. So if cortisol itself is low, what will happen to the ACTH levels? The ACTH levels will be too high, and ACTH can stimulate the melanocyte receptor. It acts like a melanocytic stimulating hormone. So that is the reason this hyperpigmentation can be present in primary adrenal insufficiency. This is very, very important. Endocrine pancreas is again the problem. Whenever there is an beta islet cells destruction, it will lead on to diabetes mellitus. But physiologically, how this insulin is secreted, that I will explain it. The glucose enters through the GLUT transporter, and what happens is there is a potassium sensitive ATP channel, the ATP sensitive potassium channel. So what will happen is this channel will be blocked. So whenever this channel is blocked, this K plus starts to accumulate inside, and they will cause depolarization, which will lead on to the entry of calcium, and finally the insulin will be released. So insulin is released along with the C peptide. So in a patient who is taking exogenous insulin, if we want to measure the levels of insulin, like endogenous insulin, C peptide can be used because they are secreted in equimolar amounts. And insulin is an anabolic hormone, all of us know, and tumor of insulin is called as insulinoma. So for insulinoma, what we can do, one thing is that we have to remove the tumor, but insulinoma will produce a lot of insulin and cause a hypoglycemia. So immediate treatment can be a diazoxide can be given. What it does is it opens up the ATP sensitive potassium channels. So what happens? This potassium will keep on moving out. All this potassium will keep on moving out. So the levels of potassium inside the cell will be less. So the release of insulin itself will be less. So this can be a primary treatment. Then diabetes mellitus, you guys know that is type 1, type 2, type 2, every feature should be known about. Then coming to the calcium hemostasis, 3 hormones are involved: parathormone, vitamin D, calcitonin. Calcitonin, I have already told you, it is a calcium lowering hormone. Whereas parathormone and vitamin D, they increase the levels of calcium in the blood. I have given their functions here. You can go through it. The parathormone final action is it increases the calcium in blood but decreases the phosphate. Whereas vitamin D, it increases both the calcium and phosphate in the blood. Calcitonin, it decreases the calcium levels in the blood. That's why it's called calcium lowering hormone. Then we will discuss the acid base disorder, and then we can wind up. Reproductive, I have given very little only, since it will be covered in obstetrics and gynecology also. You can go through the notes, but acid base disorder, I will give you clues so that you can easily pick up and score the acid base disorder marks in acid base disorder. So acid base disorder, we generally have to see only 3 things. Whatever lengthy questions are given, please don't pay attention to any of it. Just look at the 3 things. So 3 things that we have to look at is the pH, then bicarbonate, and PCO2. So remember, pH is the king of the game. Just remember this statement: pH is the king of the game. Whatever pH tells, that is the disorder. So it is the indicator of the disorder. We will see with examples, then you will understand why it is the king of the game. It is the indicator of the disorder. Then bicarbonate levels, they indicate the metabolic disorder, whether the person is having metabolic acidosis or metabolic alkalosis. Then PCO2 levels, CO2 is respect to respiratory. So it will tell us whether the person is having respiratory alkalosis or respiratory acidosis. So the pH normal value is 7.4. Whenever the pH is increasing, what does it mean? It means that the person is H plus is coming down. pH is an inverse of H plus. So it will, if it is increased more than 7.5, it is called as alkalosis. So if it is less, if it is reducing, the pH is reducing down, it is called acidosis. So this is important. So if the pH is less than 3.5, then that is an acidosis disorder. If the pH is more than 7.5, that is an alkalosis disorder. That is what you have to remember. Then coming to the bicarbonate level, the normal level is 24. Whenever it is more than 26, bicarbonate is more. Bicarbonate is not an acid, it is an alkali. So whenever the bicarbonate levels are more, it is going to tell me, and I told you bicarbonate will tell us it is metabolic. So it is metabolic alkalosis. Then when the bicarbonate levels is less, it is metabolic acidosis. Then finally PCO2. When the PCO2 is more, PCO2 is an acid, so it will cause respiratory, and I told you CO2 is for respiratory acidosis. And whenever it is less, it is respiratory alkalosis. So this we have to remember. Now we'll try to identify the disorders. And always respiratory acidosis will be compensated by a metabolic alkalosis and vice versa. Like metabolic alkalosis will be compensated by a respiratory alkalosis and vice versa. So example 1, here the pH is 7.32. Just go back and see the slide whether it is an acidosis or alkalosis. So it's very simple. It is an acidosis. And bicarbonate is 28. Bicarbonate is 28, so it is more than that. So it is a metabolic alkalosis. It is a metabolic alkalosis. So then PCO2 is 46. 46 is respiratory acidosis. 46 is respiratory acidosis. Now we have to identify which is the primary disorder and secondary disorder. So I told you who is the king of the game. pH is the king of the game. If the pH says it is acidosis, it is acidosis. Then whoever goes along with the king, they win they are like the soldiers. So the primary disorder here is we have to pick an acidosis. So the primary disorder is a respiratory acidosis uncompensated by metabolic alkalosis. So this answer is respiratory acidosis with metabolic alkalosis. This is a very, very important keynote. Here acidosis we have chosen, and one acidosis is there, so that is the primary disorder. The other one will be a secondary compensatory mechanism. And next question, pH 7.5 is alkalosis. Bicarbonate 24, it's nothing, it's normal. Then CO2 is 30, it is respiratory alkalosis. So the primary disorder is respiratory alkalosis because nothing else we have any disorder in it. So this is how we can easily identify a acid-base disorder. So remember these three things and remember these normal values. It's an easy cakewalk once you practice 1 or 2 MCQs of this. I hope you had liked the session. So try to watch the videos if you have missed any content in the previous starting or ending. Thank you all the best to everyone. Hope we can end the meeting. People who are here, can you hear me? Okay, okay, Radhikrishan. I am just closing the meeting. Thank you.